Welcome everyone to our session on bridging the costing gap, policymaker needs, and practitioner approaches. We're honored to have you join us today to discuss this very important topic that has wide implications on our health systems. Eduardo Gonzalez-Pierre, who is the Senior Director, Health Financing with Palladium, is not able to make it because he had some flight delays, so he offers his apologies. But I'm happy to stand in on his behalf today. My name is Frances Elika. I'm Director of Health Systems with Palladium. As many countries explore their pathways to UHC in this volatile, uncertain, complex, and ambiguous times, the use of costing data to inform policy and decision-making has become very critical, especially in light of scarce resources and the critical times that we're in as countries advance in their primary healthcare improvement as well as UHC journey. So it is commonly understood that use of costing data to inform policy making, decision making, implementation, and results and outcomes in countries is very critical. However, we do know that critical challenges exist. So we're gathered here today to explore, to brainstorm, to listen to experts, but to also bring our ideas together and try to synthesize solutions to some of these common challenges. Some of the critical challenges to using costing for effective policy and decision-making have been identified. And I may want to simplify by saying that some of these problems are communication problems, whereby costing experts like you and I often do not understand or know how to communicate effectively to the people who have the power to allocate resources and make the decisions about how resources are spent. And so we have a big communication gap. Another major problem that has been identified is timing problems. So sometimes the costing doesn't come at a time where it can be useful to the policymaking process and along the policymaking cycle and being given to the people who need it in a timely fashion. And today we'll be exploring some of that too. Finally, of course, this is not exhaustive, framing problems. So a lot of times we do not frame the way that we do our costing effectively, that it fits into the ecosystem or the infrastructure of existing governments. For instance, a lot of times we use methodologies that are best practice, as we like to say it, but doesn't make sense to the people who need to use that information to make decisions. And so today, we're hoping that we can bring together stakeholders that's okay. Yeah, so today we're hoping that we can have stakeholders sit together to discuss this very critical topic about how we can make costing effective for our health systems. And so we're very happy that you're able to join us today to explore and find practical solutions that can help countries as they look for relevant, effective, and impactful costing data and use for policy making, which will enable them to advance on their UHC journey and goals. And so at this point, I am delighted to introduce my colleague, Robert Coloser, who is Director of Health Finance with Palladium, who will speak to us about the overview of today's session, as well as introduce the excellent panelists and presenters that we have for today. So please stay on with us, enjoy the session, and at the end of today, we hope that we would have contributed in a big way to finding solutions that will help to bring our policymakers, our researchers, and critical stakeholders who work in this sector. We hope that we can bring solutions that can actually make their work easier and help them to be more effective and impactful. Thank you so much for joining us today.
Thank you, Francis. So good morning and welcome again. I'd like to provide a brief overview of today's meeting agenda. So we've got 3 planned dialogues. Each will start with a brief presentation by a technical practitioner, followed by a moderated panel discussion among policymakers. We're interested to hear from them about the practical policy value of each costing issue in their country context and how it can best meet their needs. Each moderator will then invite audience questions and comments, including those from folks who are joining us virtually. So the 3 costing dialogues will focus on activity-based costing to be presented by Bryant Lee from Palladium and moderated by David Koya, also from Palladium. Costing of health benefit packages to be presented by Solomon Memire from Addis Ababa University and moderated by Stefan Verget from the Harvard School of Public Health. And overcoming costing data use challenges to be presented by Carl Schut from Genesis and moderated by Francis Ilka, also from Palladium, who you just met. So we like to invite you to live tweet from this session. And there are the presenters. Oops, sorry. And here's an overview of the star panel that we've lined up for you this morning. So each dialogue will last about 1 hour, and we'll have a short coffee break following the second dialogue. And without further ado, I'd like to turn it over to Brian and David. Invite you to come up, and they will provide a high-level summary, or Bryant will provide a high-level summary of the ABC approach, its purpose, scope, methodology, and data use cases to provide background on the difference between ABC versus other traditional costing approaches and highlight the value and limitations of that method. And David is moderating the discussion, and he will reintroduce Brian and the panelists. So please join us at the front of the room.
Good morning, everyone. I'm actually pleased to introduce Brian Lee, who is a senior technical advisor with Palladium. I think in the interest of time, we allow him first to present, and then if there is any burning question, we will ask. But then we will spare the questions to the end of the session after his presentation and after the discussion, so that we are able to interrogate the issues. As you know, costing, for those of us who are taught in school, used to be very easy topic. You are taught from the production function, you go to the cost function, and you are told that to get the cost function, you assign the costs to the factor inputs. So it used to be very easy to us until I got to employment, where now I was told to assign those costs to the factor inputs. And that's when hell broke loose. And now we want the experts to guide us on how do we assign these costs to the factor inputs, because it appears like there are quite a number of issues that are involved in that assignment, because at the time we were taught, it used to be very straightforward. So I want to welcome Brian Lee to take us through one of the approaches of assigning those costs to factor inputs, so that we see whether it makes sense to the to the needs of the government. Brian Lee, welcome.
Thank you, David, and good morning, everyone. Thank you for joining us today. So I'll be talking about activity-based costing, which is one of the most common methodologies used, or ABC. Palladium, in collaboration with USAID, as well as PEPFAR and others, have implemented many studies using this approach. So I will give just a fairly high-level overview of the basic approach, and then show you some common outputs from these types of studies, and then I'll wrap up with some potential data uses. So just starting with the approach. So the main objective of ABC is to identify the actual cost of providing health services, trying to account for the ways services have evolved over time and changes in price inputs, as well as to improve monitoring. So results can inform decision-making for more financially sustainable and effective health services. We can try and optimize investments and drive efficiencies and better allocate resources. Results can also inform the development of broader national strategic plans and allows for better and more accurate provider payment rate setting. And all of this falls under the overarching goal of accelerating higher levels of country ownership, increasing local capacity, and trying to increase domestic resource to ensure sustainability. So data can be collected in a number of manners. You can do key informant interviews with the service providers. You can shadow the clients as they actually proceed through the care visit. You can look at their patient profile forms, conduct client exit interviews, and gather data from the facility data systems and records. At the site level, a variation of ABC is something called time-driven activity-based costing, or TDABC. So this is a patient-centered approach, which means we follow the clients as they proceed through their care cycle. And TDABC has 4 main steps. Step 1 is to determine the care process. So through key informant interviews, we identify what activities are performed, who performs them, and how long they take in minutes. Step 2 is to calculate something called the capacity cost rate, or the CCR, which is our main unit of measurement, and is defined as the annual cost of each resource divided by how often that resource can be used in minutes annually. Step 3, we have to account for consumables. And then step 4, we have to account for indirect costs for things like overheads, support staff, and utilities, for example. So just showing you how the capacity cost rate is calculated here, you're using personnel as an example. So you would take the clinician's salary and their benefits annually and divide that by something called the practical capacity, which is basically the amount of clinical time that clinician is available to provide services. So this would not include things like leave, sick days, trainings, as well as time spent in lunch or breaks or doing administrative tasks. So you can apply this calculation method to basically all the cost categories. So facility space, furniture, equipment, and even indirects, you would calculate a capacity cost rate for. So there are some advantages to using this TDABC approach as opposed to more traditional costing methods. Because it is patient-centered, we're directly observing the patient, and you can observe the actual resources being consumed by each individual patient, whereas traditional methods simplify by assuming that all patients are homogeneous. TDABC also involves creating something called a process map, which is, I'll show an example of later, but is a very useful tool for clinicians to understand the care process. Second, because we're using the one standardized metric, the capacity cost rate, we don't need to make or apply a bunch of different allocation methods, which can sometimes be somewhat arbitrary or misleading. Third, because it's an inductive approach, we don't have to apply as many assumptions when calculating the unit costs. And lastly, because the unit of analysis is at the individual level, we can examine variations at the patient level and at the facilities where they're receiving the services. So here's an example of the main sort of output from an ABC study, where you have the unit costs per clinical visit, and you can disaggregate this by service type as well as cost category. So this would include personnel, facility costs for space and furniture, indirect costs, equipment, typically large lab machines, and consumables. And then you can see the range as well. If you can apply the approach to different layers of the health system, you can compare the proportion of each component to the overall cost of providing treatment over the course of the year. So it might give you some interesting insights based on how these costs are distributed across different layers of the health system. Data outputs also include the average time that a patient spends with a clinician for a care visit. We also see how much time they spent at the facility, so you can see how long they actually spend waiting for services. So this can give you some insight into ways to improve the care efficiency at the facility providing services. Okay, so circling back to the process maps, here's an example of one. So each process map graphically depicts the care process for a specific intervention. So it shows you the steps in the care process, the sequence, where it takes place in the facility, who's providing the service, and that's color-coded by a cadre, and how long it takes in minutes. So these are useful because you can compare what is actually happening in practice by following the patient and compared to the standard protocols or the clinical guidelines. So then this can surface if steps are being skipped, or if there are steps being cut short in terms of time, or an unexpected cadre is providing a service that you wouldn't normally expect. So again, it can give insights into quality and efficiency issues. So I'll wrap up with a few potential data use cases. So the first one is trying to improve efficiency in the care process. So we have the process maps, which can highlight variations in care. So this can show where there are opportunities for quality improvement, more optimal staffing models, and cost savings. So to improve quality and cost effectiveness, we can try to standardize care and determine the ideal flow of patients at a clinic to reduce bottlenecks and waiting times. If you can determine what's driving variation in the way care is delivered, for example, it could be because there's not enough human resources for health at the facility, or there could be a stock out of commodities. You could try and develop interventions to address those specific issues. And then trying to figure out how to optimize the program's HRH, improving the capacity of clinicians while trying to minimize absenteeism. Second, results can inform ways to try to reduce the burden to clients that are accessing health services. So from some of the studies that Palladium did, we saw that the direct costs to clients for facility visits is high. There's opportunity costs, and this is exacerbated by long wait times at health facilities. So using these results, we can advocate for implementation of differentiated care models to increase accessibility and equity, try to identify other policies to reduce barriers and the economic burden to the poorest clients, and consider multi-month and decentralized dispensing of drugs, for example, at community outlets, and potentially try to reduce transportation costs for those in the poorest wealth quintiles. And lastly, we can use results to try to optimize resource allocation. So we have the cost data from the study, and if we can marry those cost data with health outcomes, we can see which interventions and services are making the most impact. So some of the studies that we did in East Africa, for example, we saw that the facility level costs were actually quite minimal. So you can improve quality of the facility level services with perhaps not a massive investment. You can also compare facility and community level costs to try to inform the most cost-effective points of service for key interventions, and then trying to determine the cost drivers at the above site level to identify which of those investments are making the most impact in order to prioritize resource allocation. So in other words, where is the money best spent? So that's it for me. Thank you very much. I'll hand it back over to David.
Yeah, thank you very much, Brand. And I think now I get to understand how to assign my costs to the inputs, because as you know, the traditional way used to be, we look at the number of patients who have gone through a system, we divide by the amount, the expenditure we have spent from a system, we divide by the amount of patients who have gone through, then we say it costs us so much to treat a patient. But this is now an innovative approach where we are now following that patient and trying to identify what they are consuming at every step. And more importantly, Brian has also indicated that we are also able to capture some of the opportunity costs, like the time of waiting at a facility, as well as what patients are paying out of pocket. And to me, that is quite important, because then we can inform the policymakers exactly where to intervene and to correct the situation. But to make sure that we understand this, I think I'll invite my two panelists to come forward as I introduce them. But I want to allow 1 or 2 minutes of questions, just in case you want any clarification, because I would like us to reserve more time at the end of the discussion so that we can clarify some of the issues in case they are not clear. So if there is any question, this is the time, but if there isn't, I would like to welcome my panelists before I introduce them to you. Thank you very much for making it very clear. As you can see, no clarification questions. Thank you very much. But Brian, I would also like you to sit here so that if a question comes after, we don't look for you. Yeah. So if you allow, I will also move there so that I will come and sit next to them. So, but before we start, I wanted to make sure that I introduce the panelists. Yeah, so to my left, we have one lady there called Sira. Sira is works with the Minister of Health in Malawi. She's the chief economist at the Minister of Health in Malawi. And so we have the government. So it now becomes easier for us to check with them whether whatever we are proposing here makes sense to them. Because, you know, as practitioners, we may be thinking and talking to ourselves, but these are the beneficiaries. So they need to tell us, is what we are proposing enough to deal with the needs? And that's why you heard about the bridging the costing gap, because we don't want to be talking to ourselves, and yet there's a gap that we need to fill. And so Mr. Sira will be giving some insights on whether what Brian has presented makes sense to them as government. Then on the far left, we also have somebody from the Ministry of Health, Uganda. He's a policy and financing and planning expert in the ministry. His name is Alimba. He's coming from the Ministry of Health, Uganda. So as you know, you can see we now have government. And so the gap we were talking about, we will now bridge it today, because we have the practitioner who has presented his approach. and we have the government. So we want to interrogate whether that gap can be bridged. So allow me to move on there so that we are able to interrogate these issues. Yeah, thank you. So I will start with Alimba. So given what we've had today from the presentation from Brian Lee, who is a practitioner, as a beneficiary of this approach, do you think this approach addresses some of the issues that you have as your needs in costing? And whether you think it's a useful approach the way he has presented it? Thank you.
Thank you so much. Thank you everybody for giving us an opportunity to be here. Yes, I think we, as Minister of Health, I think the beginning point is that we do actually have very ambitious targets, of course, based on the need, but also based on what we signed to in different conventions, perhaps including this one. And therefore, the resources that we have are quite limited from the economic point of view, while the needs are quite big. And therefore, as you offer services, you need to progressively look at how you control costs. And of course, COVID has also just taught us a few lessons, and that's where we are. And therefore, any solution that tries to address the challenges and gives you different approaches from the way you've been doing things is quite welcome. We've been taken through this tool, and we've also tried to apply it in our country in some of the areas, especially HIV. Issues of efficiency, if you discussed in between us and the Ministry of Finance, they always think you're not very efficient. If you go to them to ask for more money, they want you to demonstrate whether what you have is being used efficiently. Of course, that's another excuse, wanting to make sure that they can buy time so they can give that money to another sector that maybe that is politically motivating or socially viable. So when you have this evidence and you're especially able to demonstrate the process, but most important, the efficiency gains using this tool, I think is quite an important one. Of course, like you said, we're comparing to the previous one. We're used to getting averages, just giving an amount of money and then just say, this costs this. But if they interrogate it, they find that it's not quite what you are suggesting. Thank you.
Yeah, thank you. So, and maybe just to have a follow-on so that we are clear, if we wanted, for example, today to understand whether the Ministry of Health in Uganda has the figures they require to maybe treat certain diseases, is that type of data readily available?
I think Uganda, like a few other countries, we've been suffering from data. Yes, data will be available, but it's very scattered. And also, like we're saying, different methodologies. People coming, I think the chair mentioned the issue of how we do things. You are from a school of public health, you just come with the packaged information and they give me and try to tell me what this costs. But I'm not quite sure what went into that. And most importantly, when you present, people ask you, now what do you want us to help you? But you came to tell us this information is for you, but they'll ask you, what do you want us to help you? Two, of course, sometimes we can pick that information just because somebody has asked it, and we say, who has this information around? Then you say, okay, there's a researcher who did this. We can use it. But sometimes when you reach a point of presenting it and you're asked by either a partner or a governor, you can't explain. So I think that has been the challenge. I think the process is, if we've worked through the process, then we would be able to have that. And I think we have an opportunity to use this in a structured manner so that we're able to have a database and a reference point.
Okay, thank you, Alia. And maybe to come to Tasira Mopehu from Malawi, given what we have observed today, do you think this type of data will be useful to you? And how can the results that Brian Lee has presented today be made use of in the case of Malawi? Any thoughts around this?
Thank you, David, for that question. I think as a country, we mostly are advocating for two issues: more health for money and more money for health. So using the Abuja Declaration, we consulting Treasury to at least ensure that 15% of the GDP goes to the health sector. Of course, as a country, we haven't been able to do that. So when it comes to more health for money, which is essentially efficiency issues, we're looking at various approaches of improving efficiency as a country. Now, looking at these costing models, I think it's much easier to analyze what basically is going into the inputs, the costing of the inputs, because you're costing at each level of the service delivery. You're costing the consultation, how much it's taking when they go to the lab, and if they are at all admitted, how much that is costing, like the presenter has already indicated. This is essentially patient-centered. Now, looking at from the government point of view, I think if you know basically what goes into the inputs when it comes to service delivery, I think as a country, you are in a better position to introduce reforms. So in Malawi, most of the services which we do provide, the health services, are free of charge. So for instance, if there can be reforms, let's say there should be patient contributions and the other reforms. I think using this kind of costing, it's much easier, because whatever you're proposing to Treasury or to the Office of the Presidency, you backing it by data, the costing data that's on the ground. Thank you, David.
Thank you very much. And I think I'll get back to you with another question, because it's important to understand whether this type of approach actually solves your problems completely. But before we get there, I want to Alia just to tell me, for example, given what we have seen today, do you think there is any further research that needs to be done to be able to address your needs as a government better than what the approach has shown? Over to you, Alia.
Yeah, I maybe we didn't have enough time, but I think yes, like my colleague has said,
yeah,
we are currently in an era of reforms.
Okay.
Simply because if we need to be thinking and innovating. Right now, in Uganda, we've been doing what we call strategic purchasing, piloting it. And the indicators that you choose and the cost that you attach. There's been a very big debate as to whether what we are charging for cesarean section, or what we are paying, is what they should have. Fortunately, we're doing it for public facilities, and because they had the government subsidy, so we didn't have a lot of problems. The private not-for-profit did also have, they have a grant, a subsidy from government, but the private, we wanted them to participate and they couldn't, because they felt the cost was not informed by, the payments were not informed by evidence, so that their own costs, but hadn't done this in the field of RMNCH, basically, so we didn't have that. So perhaps we would have to look at that. also designing a national health insurance scheme. Of course, it has been taking for long, over 20 years, I think, debate and the design, but we're about to have it in cabinet and parliament. And what happens while we're there is everybody wants to be seen. Every condition should be there. If I'm a minister and I suffered from a certain condition, when you're discussing the package, it must be there. Then if I have a relative who suffered from a certain condition, I don't see it in the proposed package, they must add for me to pass the bill. But what does that mean in terms of cost? But if we went through this process, I think we'll be able to prioritize, but also be aware that what we are suggesting is more efficient and it can give us value for money. I think we need to look at that. Then another area I think we need to focus on is, of course, how do you do this within the existing framework of government? Should we have experts come and do it? Or should we have a combination of experts and and which systems do we have in terms of information systems? Of course, we have very scattered health management information system, financial systems. So how do we get our best costing methodology or approach to be embedded in the system? I think these are some of the things we may need to think through. Thank you.
Yeah, thank you very much for those insights. Maybe Mr. Sira, I wanted to find out from you how we can make the cost data to be routinely available. Do you think that will be something useful to you as a government, or you will be comfortable with a one-off type of costing? Mr. Sira.
Okay, so I think making reforms and then making the data not leader available is one of the major problems which many countries face. So looking at the this costing model, I think it's like I indicated before, it's very practical. For instance, in my country, Malawi, we have a public-private partnership with the Christian Association of Malawi. These are religious institutions, and also the Islamic Association of Malawi, where we do use their facilities for general health service delivery. And then at the end of the day, they provide the invoices to government, and government is required to pay. So you're looking at this PPP, this arrangement, and the efficiency. Is it the way we're doing it? Is it the most efficient way of doing it? So I think this kind of study, like in my country, can help a lot, because you'd really know the inputs that are going there. And in terms of making, like implementing this, I think as a country, we can look at the data elements, like what he presented, what really goes into the health service delivery. And then after we do cost those services, like a patient-centered approach, then we look at issues of capacity building. So the capacity building shouldn't only be done at the central level. There should be capacity building at the national level and the sub-county levels or the district levels. And this can be done for maybe 3 to 4 years in a phased approach, so that at least at each and every level of health service delivery, people know what this costing essentially means. So as a country, we've sort of started this this study, the costing of health service delivery at one of the central hospitals. So it's really difficult to find data, but I think by and by we're going to get there. But what is mostly important is that if this can be implemented, it has to be a phased approach, not just a thing that's done by a consultant maybe for 1 month, maybe for 2 months. It should be a phased approach, something which can be done for, let's say, 3 to 4 years to ensure that there's a smooth transitioning. And at all levels of the system, from the primary health levels, they're able to understand how this costing is supposed to be done and how it can be implemented to ensure that there is efficiency at all levels of the healthcare delivery. Thanks a lot.
Yeah, thank you. I think so that I'm very mindful of you, those participants who are here who may want to also ask a question or make some contribution. I think this is an opportunity for you to also do that. And if you raise your hand, we will take a mic next to you so that you can also contribute. If you have a question, contribution, how you think this approach will be useful, that would be great to us. Yes, please pass the mic to him. And then there's one at the back.
Hello, good morning. Thank you to Brian and the panelists. My name is Oshoremi Ogbe. I work in Nigeria for the government in primary healthcare. It's not really a question to the panelists because I can really associate directly with the comments you've made and I understand it clearly. It's really for Brian to give some comments, right? So the ABC costing is similar to the tools WHO tends to use, particularly the older COSTIT tool. And one thing that happens is that no matter how well you do it, once you extrapolate the cost to population, it always feels ridiculously high, right? So, and I think that's because of some inherent duplications that occur within the costing. So for instance, most times this costing is program-based, HIV, childcare, and things like that, right? And part of the costing elements are that of costing a health worker, and you're costing also the facility, the space, the infrastructure. So two things happen. Whether that health worker sees 100 patients or sees 2 patients, the health worker is going to get paid the salary, the same salary. And in that space where the health worker is providing that care, there are multiple other activities going on in that same space. So are there practical ways to factor this in and discount them so that they don't become sort of like duplicate cost or some kind of almost invisible elements that tends to always increase the cost? Because that's always the challenge. When you finish costing and now bring it forward, and you have taken it to the population level, it's like, who is going to pay for this? Where's the money going to come from? But if you go back in reality with even minimal additional disbursements, I'm talking from the government perspective now, into that program, you find the program is still running because there are certain costs that are part of the program, but not necessarily paid for by the program, particularly salaries, particularly infrastructure, particularly equipment, except there are new investments that are required by the program. So it'd be good to hear your thoughts about how that aspect can be managed, because that's one of, I think, the bottleneck. I remember working to do the costing for primary care, more holistic costing, but using this approach for a state. And when we saw the final results, went over and over it, yes, it made sense, but nobody had the courage to take that to the governor. Like, we will get this kind of money from. And it's really because of these inherent things where we do some kind of duplication to start realizing it, particularly as regards to infrastructure and salaries. So I'll be happy to hear a comment. Thank you very much.
Thank you. Thank you very much for that question. Like we said, practitioners are here now. They can address. There was another question from that last row.
Thanks very much. My name is Jackie Mia, and I'm with the Health Economics and Epidemiology Research Office here at WITS. So I wanted to ask a question of the panel as well. We've done a fair bit of this kind of costing, largely primary cost data collection, and certainly in our experience, while it's incredibly valuable, it's also very resource intensive. It takes a huge amount of people time and funding to be able to do this work. So I'd really like to know from Brian and from the panel, what would be your suggestions as to how we could more routinely collect this data and in a less costly manner? Because I think that's something we all want it, but how do we get it in a way that is not going to cost a fortune? Thanks.
Thank you. Yeah, so maybe we address those two questions, then we can allow another round. So there is a question our brother from Nigeria has asked regarding, and this I think, Brian, you will be better placed. He's saying that when you do costing, the numbers mean they make sense, but when you extrapolate them to the population, they become like something different. And so he's asking whether this approach takes care of that type of dynamic in the way you extrapolate the costs to the population.
So the methodology that I presented, the time-driven activity-based costing, it's specifically designed to try to avoid some of the challenges that you mentioned, which in terms of double counting. So by observing each patient, you can see the actual resources that are consumed for that actual patient. And you do that for the entire samples of the study. So that is and it sort of gets at the second question, is a much more resource intensive process and in terms of time and money. But then you don't, the point of doing that is that you get a more accurate estimate of the unit cost. So that's sort of the trade-off. You can do a quicker allocative method that will take a lot less time and a lot more resources, but then you have, you may introduce some noise in terms of duplication. I hope I addressed your question. Yeah.
So I would like to agree with the lady at the back that this methodology is really resource intensive. But then when you want to make major reforms don't come cheap. So I should think that digitalization here could take a bigger role. Like in the first years, you really need to invest time and resources, so that you have the baseline of this data. I should think that in the subsequent years now, you only look at what which cost factors have changed. But at the beginning, you really need to invest those resources and the time as well. Thank you.
Yeah, thank you. Feel free in case you have any follow-on question. The panelists will still be around. Even after the session, we can discuss them further, but I see a hand there. Yeah. Yeah.
Hi, I'm Paul from UNSW Sydney. Just a quick question regarding, maybe just a quick context. I'm from the Philippines. So in the Philippines, like the National Health Insurance actually like trained the facilities to actually conduct their own costing. And then it actually like they somehow like integrated it with the work and financial plan of the hospital. So it's not really like at least resource intensive in the case of the Philippines. But my question is regarding the actual costing. So how do you perform the processing and analysis of that activity-based costing? Like what software do you use and what techniques do you use, for example, if you want to account for uncertainty? Because I think one of the challenge with costing is that when you extrapolate it to a bigger population, like the uncertainty is amplified. So like the cost may actually be bloated compared to the actual cost that we should be expecting. Like do we use Monte Carlo simulation or other techniques to actually account for uncertainty?
Okay, thank you. Let's take one other question there. Then.
Good morning. There's actually a question on the online platform from Almero. He's asking when transitioning from standard service design to a differentiated service design system often have to be funded and run by both the transition. Okay, so I have to read it again. When transitioning from a standard service design to a differentiated service design system, often have to fund and run both during the transitioning. Does the panel have any experience or advice regarding the costing of this transitioning?
Thank you. Those are very important questions. The first one, maybe this brand, you can handle them. The first one is about the software or the technique that you use to analyze this ABCM data. And the second one is how do you use ABCM to capture the transitioning from the normal standard costing, standard service to a differentiated care service where you are maybe coming in with a different way of providing the same service. Over to you.
So I'll answer Mark's question first. So that would be a great example of a situation where services, the way services are delivered have changed over time, in which case the previous unit costs aren't up to date, in which case that would be a logical time to do an update in terms of the costing, because the way the various steps in the process will be different. So the other sort of time when it makes practical sense to update the costing is if there's major changes in the price inputs. So then once you cost the differentiated care model, then you can compare to the sort of baseline standardized care and see what the cost difference is. The first question, it's largely Excel-based mathematical sort of calculations. We did use statistical software to analyze the client level data. In terms of accounting for, I guess, variation, we didn't do any additional sort of modeling, but we tried to have a large enough sample size where we thought, we feel comfortable. Okay, this is, we feel comfortable in the average over the entire sample.
Okay, thank you very much. I think we are running over our time, but we are okay with that. Okay, thank you. Maybe make your follow-up question. He has a follow-on question so that.
Voice a lot of people, but so because usually when we do costing, so we would have like a range of values, like for example, the minimum, the maximum. And so how do you actually account for, do you like just come up with an point estimate, or do you like have a distribution of the cost? How do you like?
Yeah,
because if
one of the graphs, the outputs, yeah, we do show the range, but in terms of what we report as the unit cost, we take the average.
So in case, for example, for one cost item, if you have a maximum value, you will just add it with the maximum value of the other cost items. Is that how it works? So basically propagating the uncertainty.
Can you
I mean, for example, like in costing, like we have like multiple cost items, right? And each cost item would have a minimum value, for example, and a maximum value. For example, the price of the drug, the salary of the personnel.
Yeah.
So in coming up with the cost estimate for that particular service,
yeah,
how do you synthesize those maximum values and minimum values? Do we just multiply all of them, or do you do?
No,
like
we take the average.
Average
for each input. Yeah.
Okay. So okay.
Yeah.
Colleagues, my name's Carl Shooter from Genesis. I just wanted to make an observation, having done a fair bit of traditional activity-based costing over the years, and speaking to the comment that my colleague here made earlier on about sky-high estimates, is that I think we're getting really good at estimating the direct cost of service provision, especially using time-driven ABC, where you're observing quite a large sample of clients. But I think where there's still a little bit of guesswork is with the allocation of the indirect costs and the infrastructure costs and other things. And to some extent, this happens because we so often get asked to cost only one service in an integrated setting. And it becomes really difficult to validate the allocation of some of those indirect costs. Of course, we try and use either patient flows or whatever as allocation keys, but the reality is it's still a best estimate. And I think that is sometimes where, I'm not sure if it's duplication or overstatement or understatement, but where the accuracy levels aren't as high as they probably should be. And what was really good about the output from the ABC study is it showed how large those above facility and indirect costs actually are. And so if there's anywhere where we need to focus maybe a bit more attention, it is in that space. Thank you very much.
Thank you. There's another question there, please. Thank you for that comment. I think it makes sense. It makes sense.
Yes, one quick technical question. So you're following the patient time, but in doing so, you can calculate the provider's direct service time. How do you calculate the provider's indirect services like administration per patient? So I see how you can calculate providers' direct services from following the patient around, but aren't we missing other information? And so how do you address that?
Yeah, that is a challenge, because once the clinician is done with the consultation, they may spend 5 minutes filling out the paperwork. So we try to have researchers sort of pop back in and ask them, as well as during the key informant interviews, we can ask them, non-patient facing what you're still doing your clinical work, and then try and get an estimate. But it is a challenge because if you try to follow the patient and the provider, then the cost for the study really.
Okay. Thanks so much. My question is to my colleague from the Philippines. You have said that you allow individual facilities to do their own course. Two things. I would like to know what happens if each facility gives you their own course. What happens then? Do you do averages, or each one gets reimbursed based on their course? Yeah.
Okay.
Okay. Okay, good.
Okay.
Good. Thanks.
Thank you. Pass it on to the next. Yeah, please.
Yeah, I think the issue of the treatment of let's call them the labor cost, for example, the direct and indirect labor, as in accounting, for example, the indirect labor would extend beyond the time facing clinicians facing time with patient facing time. So for example, the HR, human resource, are not interacting with the patient. So I think I think for me that depends really on the structure also of the system, the financing, whether publicly provided or privately provided, and then the purpose of the costing as well, the purpose of the costing. Yeah, but otherwise, I think it's a challenging space. For example, in public finance systems like in Malawi, where what you can trace at facility level, you could do the time motion. Depending, so mostly you are observing, if you are observing the patient, you need to work out another framework to build up the non-clinical time for the non-clinical cadres, and then of course then you get into some tough processes to estimate how much you allocate that time. The accountants, the human resource, the drivers, where you can't observe via stress in the patient. Yeah, and then of course in those systems, then the costs built around the patient will then need to also take into account, for example, in our context, we can't observe we can observe the inputs. So you need another external cost database, for example, that you can link to the inputs. But the inputs, for example, if they are procured by a district council, distributed facilities, then there will be a lot of discrepancies between. So as you build from the facility, you could underestimate because at least the assumption I'm making there is that then the efficiency losses between the levels of systems that handling the procurements are then ignored. So I think they're balancing how to accommodate the inherent inefficiency of the system so that then you don't program at a level where you create mechanically, for example, stockhouse, because you costed just what you observed at the facility. I think for me, those are really practical challenges. Yeah.
Yeah, thank you. I think, Brian, you can just comment finally on how you cost the commodities that are supplied from elsewhere to the facility. Because if I got you right, you are basically saying that irrespective of where they came from, you are monitoring what is actually going to the patient. And therefore, your challenge is just to find out the cost of that material or commodity that goes to the patient. But I think it's a valid question he's asking in case there is any methodological approach that addresses what he's saying, like commodities procured elsewhere and supplied to the facility. And then we will be wrapping up shortly. Yeah.
So in terms of you said a lot of things there, but in terms of the commodity price, it would be the purchase price, basically, whether that's medical stores or to some government procurement. But just a comment on you're getting at the indirect question in terms of support staff like accountants and such. You do point out kind of in terms of the accuracy, definitely that is, you have to make a bunch of assumptions, and it's probably the sort of most uncertain aspect. But usually the indirects aren't a huge proportion of the overall costs. But there's not an easy way to do it. So you have to make a bunch of assumptions. So you do point out something that's a challenge using this approach.
Thank you. I think I want to come to a close, but you have a question?
Okay, thank you. So one of the emerging themes that I heard people mention is around utilization of the costing data for efficiency, and also to identify, I believe, Sira, you mentioned about more health for money. And so the other side of the coin is a lot of countries, in fact, I would argue almost all countries are also working towards improving service quality. And because the methodology really focuses on what you're observing and what the current, what is happening currently with service provision and the cost of that service provision, I'm interested to hear from our representatives from the government side. What is the view from within the government around quality services and the investment requirements related to that, and how can the costing technicians better help to generate evidence to further the interests of your governments? Thank you.
Thank you for that question. So when we're talking about issues of more healthy for money, there is no compromise on quality, because you're looking at several methods in which service provision can be done, and then trying to ensure that as you're delivering your healthy services, you're doing it in a more efficient way. So how can that possibly happen? So for instance, you're looking at movement from maybe paper-based data capturing to digital health data capturing. The unit cost of having this data, for instance, if you are to digitalize, can maybe reduce by half or maybe a third. So you're looking at several methods of delivering the same quality of health, but then with a reduced cost. So essentially, I think when we talk about, as indicated before, when you talk about the issues of more healthy for money, the main emphasis is that the quality doesn't have to reduce, just have to ensure that there's efficiency in how we're implementing. Thank you.
Thank you so much. I think, yes, I like the tool because you can, as you go through the process map, you're able to see whether people are doing the right thing. And the challenge I think we've been having is investing which equipment, which staff, at which level. And sometimes we'd make assumptions and have an equipment at a certain facility. But actually, if you did go through the process, you'd maybe find that that is redundant, because at that level, you don't need maybe a CT scan, but you've put a very investment there. So it affects both the cost, but also the quality of service. So I think, yes, I think the costing team needs to help us bring out the component of quality using the costs, so we are able to be efficient. Of course, also tied to, if we are doing something that is not standardized, then it means there is poor quality. And I think also had a discussion that perhaps there's very high out-of-pocket expenditure, which comes out even if you are providing free services. I think I had Malawi, but also for Uganda, simply because either people perceive the quality, which may not be actual, but simply because the way we do the way we run the services, somebody is doing what not supposed to do. But if they did the right thing, perhaps the quality would be okay at the same cost.
Yeah, thank you very much. I think we are coming to the end of our session, and I just want to emphasize that coming out from our discussion is the issue of communication, because remember, Francis started by saying that some of the challenges could just be communication. So the question of, you are from government and we are from the practitioner, are we communicating to know exactly what you are looking for? Because we could be costing, but maybe your ask was different. For us, we give you this, but maybe you needed something else. So I think what it boils down is to actually have an understanding of what we are costing. And as all of you know, we have a lot of costs out there. If you start listing them, marginal cost, variable cost, fixed cost, opportunity cost, and so on, then you will be like, when the government is asking, which of those costs are they asking for? And what can this approach provide? So that we have a common understanding of what type of costs are required. And so thank you very much, ladies and gentlemen. I think we come to the end of this first session so that we allow the second session to start. Thank you, unless you have any burning question. Thank you. Thank you very much.
Okay, thank you very much. And we'd like to welcome our second dialogue participants. I'd like to just reintroduce Solomon and Stefan, who will talk to us, excuse me, who will talk to us about designing and guiding countries towards universal health coverage and estimating the cost of packages of health services, which is not at all a straightforward exercise. And we will explore also, or they will explore, the wide variation in the way costing methods are interpreted and implemented. So without further ado,
yeah, no. Hi, good morning, everyone. So we're going to move to a practical implementation of great importance, which is how we apply some of these costing methods for the design of benefit packages. And what we will start with is a presentation on applying costing for selecting publicly financed services in the context of Ethiopia. So it's a great pleasure to have Dr. Solomon Memiaye with us today, who's gonna tell us about his work in Ethiopia. Solomon is the director of the Addis Center for Ethics and Priority Setting at Addis Ababa University, and in many ways a leading figure in health economics in Ethiopia. So over to you, Solomon.
Good morning. Thank you, Stefan, for the generous introduction. I'll be talking about the costing practice in low and middle income countries. And what could be the challenges that has been faced in costing of the health benefit package in the settings, and the practice, the first challenges, and finally I will end up with some recommendations. And probably we hope that afterwards there will be that would stimulate a discussion to come up with more recommendations that guide countries in costing their benefit package. You are all familiar with the UHC is the top global agenda, health-related global agenda that is supported by both the World Health Organization and the United Nations. This is part of the Sustainable Development Goal 3. And the resources available to finance healthcare in individual countries are closely correlated with their wealth. And richer countries tend to spend more on health than poorer countries. And poorer countries don't have the fiscal space to spend more on health. However, no country globally is sufficiently resourced to finance these global or aspirations around UHC. And development of health benefit package has been established as a tool to ensure government commitment toward this progressive realization of universal health coverage. And when we talk about costing and health benefit package, the costing exercise, the actual costing exercise depends on, our objectives and scopes. And if our objective is, to help in prioritization of, equitable and efficient service inclusion within the benefit package, our costing exercise might not be the same if we are planning in budgeting and implementation of health benefit package. In this exercise, one might consider that if common, cost items, if they are not included, they may not matter. But for here, we have to include, every cost aspect because it's important in the delivery of, quality healthcare services to the population. Therefore, the costing approach that we follow will have important ramification in this regard. I think this is, the overall framework, to contribute to the overall cost. Thank you. We have patient level costs. What is usually costed in most benefit packages, this level. And sometimes it also considers health program related to health programs, which are included in this area. And some costing exercises also include, this aspect of, the health system, which is important. Depending on the extent of, your benefit package, your coverage level, it might require that you have to strengthen or improve some aspects of the health system. Therefore, if you are, in order to deliver quality services, if there is a need to strengthen or improve this, then one should include costs related to strengthening or, improving these health system aspects. The other thing in the costing exercise is, the health program costs, which may, when you implement some program aspects, for example, NCD programs, or it might be HIV or other programs, there might be an included training package, of human resources, you have to cost for, supportive supervision, monitoring and evaluation, and other aspects. There are also, these administrative overhead costs that should be addressed in the costing exercise. And the most important is also to address the patient level costs, which relate to these items, which has been extensively described during the FPZ presentation earlier. But it's also critical that one should account for efficiency gains along, this in the costing of for the health benefits package along program lines. One may, as was earlier presented, one patient might receive several services along different program lines, and that to be accounted. And this might result in some gains of efficiency that might be required to be accounted for. And according to, this analysis, in 27, a group led from WHO led analysis of, the cost to estimate achieving health-related SDGs in low and middle-income countries. And it found that 75% of the needed investment would be for program and system elements. 75%. This is huge amount. Therefore, without including this, we cannot deliver, the quality services that are required to the population. Another analysis showed that this is for sexual reproductive health programs. Program and system costs accounted, for 60 to 65% of the total projected costs. This is a systematic review which tried to assess, costing of essential health services package, and it included 19 countries and it accounted for 29 studies. According to the systematic review, it has assessed what cost categories were addressed in the costing of their benefit package. And as you can see, most patient level costs were addressed substantially, but when you come to infrastructure and other system costs, the figure was very low. Therefore, in summary, the systematic review showed that 97 reported health system perspective and 76% used bottom-up costing approach, which is an important approach, but sometimes it requires to be supplemented with top-down approach to account for other cost items. And in 38% of the cases, they used One Health tool. And in 41% of the cases, they used both normative and empirical cost estimates, and 51% undertook scenario analysis. And this is one of the huge gaps actually. And there was substantial differences were observed in the costing methods and reporting standards. Another review, which was done in 5 countries that included Afghanistan, Ethiopia, Pakistan, Somalia, and Sudan, showed that, critical challenges in the costing approach within these countries. One of the most important finding was the inconsistent application of costing methods and measurement errors and data reliability issues. And despite these errors, most of these countries didn't undergo scenario or sensitivity analysis. The other important thing, which was I heard being mentioned earlier, is lack of adequate capacity building at country level to do these costing exercises. And the other important lesson for challenge that was identified was lack of integration between costing and budgeting. And they cost the health benefit package, but that's not linked to the budgeting process. Unless it's linked in the budgeting to the budgeting process, that health benefit package is unlikely to be implemented. And this table shows, the sensitivity and whether sensitivity analysis was done and what kind of sensitivity analysis were conducted in these 5 countries. Any type of sensitivity analysis was reported in 3 of the 5 countries. And, different human resource was accounted in 2 countries and different scenarios on extent of coverage in 2 countries. And along these lines, 1 country sensitivity to different assumptions was only contracted in 1 of the countries. Therefore, this is, one of the practices that's not done regularly. And the key challenges identified in generating valid cost estimates is, it has been, said even previously, timely delivery of cost estimates. There is significant delay in, computing these costs and presenting in a timely fashion for decision to the policymakers. Therefore, this is one of a critical gap. And the other is the availability of, high quality data. And this is often lacking. And there is a huge uncertainty around, coverage or utilization estimate, which might affect, our cost estimates. And often it's hard to account for economies and diseconomies of scale. Yeah, and the level of existing efficiency or inefficiency may not be taken into account. And the key recommendations that has been forwarded in some of the reviews were, developing more systematic guidance and standard ways to implement costing methodologies, particularly regarding the treatment of health system costs. And we should have, more platforms that increase availability of reliable data sources. This has been a key challenge, actually. And, and we have to acknowledge range of uncertainty in costing results, and we should integrate sensitivity analysis. And the other important thing is long-term capacity building and, institutionalization of this costing exercise within each setting, especially within the Ministry of Affairs and, other collaborating institutions. The other is closely linking costing exercise to public budgeting. This entails that, to ensure budget is considered as a purpose of costing exam. Therefore, we should work closely, with responsible agencies like the Ministry of Finance or budget officers, even when we think of revising, the health benefit package, so that this will translate to planning and budgeting for health benefit packages. And the other thing to tie, health benefit packages, to align the health sector strategic planning process. I think this is all from my side. Thank you very much.
Thanks. Yeah, thank you very much, Dr. Salman, for this excellent overview of costing implications for benefit package design. Is there any, before we go to our panel discussion, are there any burning questions for Dr. Salman on the presentation? Okay. Yes, please. And can you say your name and before you say your question? Do you have a microphone?
Good morning. My name is Sira Atakra from Ghana. Please, Doc, in your presentation, I think you made mention of the fact that poor countries have no fiscal space. And also, as part of the challenges for this costing, it was also indicated that there are some delays in the costing estimates. Do we see this as a correlation with the no fiscal space that you mentioned? So is there a correlation between the delays in costing estimates and fiscal space? Thank you.
I think the most important, probably critical challenge in delivering the cost estimates in a timely manner is one, the availability of good quality costing data within that specific setting, and the expertise to generate that costing. Therefore, these are the key critical challenges which might impact the timely delivery of, costing estimates to policymakers. In the background, if a country is, poor, and that might play in having, developing enough capacity or in training, enough people which can, perform such costing exercise. Otherwise, I don't see direct linkage between the two.
Yes, please. We had also one question in the back after. Yes.
Morning, my name is Linda. I'm from Kenya. I have a question in terms of the costing of the actual services. So we understand on the universal healthcare coverage, preventive services are equally something that we need to look into. So my concern is, as we focus on the actual provision of care, are we looking into issues around costing of preventive services? Yeah.
Thank you. I think this is an important question. Usually, the benefit package concentrates on, concentrates on interventions that could be, first delivered at primary healthcare level. And, this includes, the important preventive aspects like immunizations. Yes, I think. And this will focus on, preventive aspects that include immunization and other preventive aspects. And this has to be included in the costing exercise, actually.
Yeah. Hi, thank you. My name is Jeanne-Marie Tucker. I work with the National Department of Health on design of their primary healthcare NHI health benefit package. And I was interested to hear that you said that the approach to costing would need to be slightly different depending on whether you're looking at planning, budgeting process, or whether you're doing priority setting. Now, those are both obviously themselves linked as well, but it is often quite overwhelming to know what type of costing to start and where to focus that. So I was wondering if you could talk a little bit more about those and what the difference would be.
Yes, I totally agree. These processes are usually linked. But if your primary purpose is not budgeting, but only prioritization, then you might follow a different costing approach than if your plan is for both or one aspect of budgeting only. What I'm trying to pass here is the budgeting aspect should be comprehensive costing that wouldn't compromise delivery of quality services to the population. If it's prioritization, you can just avoid some overlapping costs across different intervention because they may not matter.
Great. One last question before we go to a panel, please.
Yeah, thank you. There's a question from Winnie. Winnie wants to know how to cost the benefit package in a hyperinflationary environment. Hyperinflationary environment like Zimbabwe. Especially if the process can be long. Over.
Great. So on that note, what I'm going to do is we're going to move to the table, and I'm going to invite our panelists and Dr. Salman to join on the table right there. So please, and I'll briefly introduce our contributors. All right, so please come, Tesfaye. So what we're going to do now is going to have a discussion around the implementation of this thinking about the costing a benefit package in the context of 3 countries. So it's my pleasure to have with us today 3 panelists from 3 different countries. Tesfaye Mesele from the Ministry of Health in Ethiopia, Dominique Nkoma from the Health Economics Policy Unit, College of Medicine, University of Malawi. And then we have Regis Itimana, who's Chief Benefits Officer on the Rwanda Social Security Board. So what I will ask each of you, perhaps starting with Tesfaye, is, perhaps if you could think in each of your respective countries, Ethiopia, Rwanda, and Malawi, about couple of key challenges you see in terms of, thinking about the costing and then the implementation and some of the critical gaps. Please, and Tesfaye, over to you.
Good morning. Thank you very much, Stephanie, and thank you also, Dr. Solomon, for an excellent presentation. With regard to the key challenges while we do costing in different countries, for instance, in Ethiopia, though it has been already well said, one of the key challenge for me is knowing the true cost or the actual cost of a given service provision, because most of the time, when we do costing, we start with from who or which service is financed, okay? But with the starting point has to be what the real cost, okay? Then the who is going to finance or which is unfunded or the like can come later, okay? So that's the challenge. That's why also when it comes to the point to choose different types of costing methodology, whether you call it activity-based or other form of costing, because it might be great first to know the true cost, okay? And as it was well said also, depends on the purpose of doing that cost, it varies. But for me, there has to be at some point a benchmark, knowing that true cost, and then you can build up on that. For instance, in our country, in Ethiopia, Ministry of Health has done recently the essential health service package, okay, with a all list of the services. And also following that, there were also a strategic plan, we call it health transformation plan, and we have also an investment plan, 3 years. And follow that, there is also currently being conducted the health benefit package by Ethiopia Health Insurance Services, okay? For me, all those has their own cost, but depends on the scope and purpose. It is a little bit varied, but if they all follow, first knowing the true cost, one can be built on the other one rather than fragmenting, doing different types of exercise, okay? So I would say the challenge is knowing the true cost and also linking that cost with budget and also expenditure tracking and the like. Because when you talk about costing, most of the time we focus only on the cost aspects, okay? But for me, it relates with also what? Budget, as well as also knowing the expenditure or tracking, okay? And the policymaker also would like to know those three dots are connected, okay? But in our country, in Ethiopia, the challenge is, for instance, our accounting system or the health finance information system are not program-based. We have a program-based budgeting at a national level. We call it because Ethiopia is a federal country. But when you go down to sub-national level, there is no such practice, okay? So it's a challenge. We used to wait to get such expenditure detail analysis from health account survey. That's periodic every 2 to 3 years or in the like, okay? So there is no kind of an active and ongoing monitoring of the cost as well as the expenditure, okay? So that's really important for policymakers to have an evidence-based decision-making and also policy. Why I say that is because for me, costing is a turnkey because it can influence the load aspect of the health system, not only about knowing the cost, okay? Because while you do costing, you can also determine the cost drivers. And through that cost driver, you can also suggest what type of intervention or approach can modify or increase the efficiency. Because at the end of the day, in health, in any system, while you talk about finance, first and the priority is whether you are using the existing investment efficiently or efficient resource utilization. That will come through what? Cost reduction and improving productivity. So unlike the others, because there is different types of practice in different countries, for me, doing costing has equal priority as doing the overall system. So it has to be started from the inception, from the beginning of doing any strategy. So we can do that way and we can improve the overall system. But these days in Ethiopia, there are a lot of interesting practice and there are very promising collaboration among development partner, implementing partner, and the government agencies like Ethiopia Health Insurance Agency, Ministry of Health, and the like. And there are good practice and hope that will bring a lot of result, positive result. Thank you very much.
Thank you. So I think mine is also very close to Ethiopia as our neighbors. Maybe to show, to maybe start giving some background. The recent health expenditure review have shown that 50% of total health expenditure is by the government. Insurances, we manage two health insurance schemes that cover 90% of the population, but we only spend around 14% of the total expenditure. So it's so small. And that shows what he was mentioning about the program elements. Sometimes they are big because they represent a big part of the expenditure. And then out of pockets, that is representing about 10% and 27% from the donors, development partners. So that shows that if we want to account for all the resources and ensure efficient allocation of resources, I think if I rank them from one to last, number one is government resources and donor-funded project. I think if you get it right, you'll be covering 77% of the resources. But I'm here from the health insurance. I'll be covering that part. So for the benefit package, it's only recent that we changed our legal instrument to start a true benefit package assessment using HTA, and we started with a pilot for the cancers, all the cancers. What we realize is that much as you can find evidence around the globe, costing evidence is not transferable. So you realize that the effect of the cancer drugs might be almost the same, but when it comes to costing, we need to rely on our own cost. And fortunately, a few years before we start this exercise, we had conducted as part of another exercise of the community-based health insurance scheme that is covering more than 86% of the total population. There was a study on sustainability, and the whole costing exercise was conducted. When I was trying to read and through the evidence and through the slides of different presenters, I think it was an attempt of activity-based costing, but it lacked some of the ingredients, which is around being patient-centered, following patient flow. I can probably guess it was due to time, because it takes a lot of time if you want to follow the patient, have a good sample and see what is being delivered. I think trying to find shortcuts such as interviews with the experts, how much time do you spend on this case? What are the elements do you put in? So there are risks of overestimating or underestimating to one point. But when it comes to time use, I think sometimes you can get it off. One of the shortcuts that the costing have used was to use the standard kind of time elements. A consultation, for example, they said, what I remember very well is secondary care, what we call district hospital. A doctor doing consultations will spend at least 20 minutes. And we're trying to argue, because it was commissioned by the Ministry of Health, and it was to inform tariff. And as health insurance, you understand, we want to defend our resources. We said this is not true. This is not happening. If you multiply all the consultation, we have about 16 million consultation a year. With the standard time, you are trying to say, we don't have these resources, we don't have this time. And they said, no, this, even if it is not the case, this is what should be done. But we said, no, we are not paying for what should be done. We are trying to pay what is available. So I think activity-based was the solution. We commissioned a small exercise. We sent our staff to watch from the entry to the exit. We realized where we are counting 20 minutes. In primary healthcare, it is actually 7 minutes. And in secondary care, it was 11 minutes in the consultation. And when you do the difference in the money we were supposed to pay, it was huge. So I think I can although it is time consuming, I think it gives the best estimate of what's happening. And I think it is good for the payer because you are being fair to paying what is happening rather than paying the ideal, which will not happen. So some of the challenges, one is it consumes time, resources, and skills that sometimes are lacking. Sometimes it's a methodology that you understand that you need to have a consensus between the providers and the payers. Sometimes it's not easy. In the beginning, they don't understand the concept. When you present the number, that's when the discussion starts. So methodology, everyone is agreeing, yeah, this is good, go ahead. When you bring the data, oh, payers are saying, no, this is not true. And provider, no, this is not fair. I think that's what we have been getting, particularly with the private sector. And because of that, actually, this is being feared. It has been pushed mainly probably by insurances far away because we don't want to go. It is 1 year process that is endless, that is bringing a lot of discussion, heated discussion. The last point I want to discuss is about financing. I think activity-based costing can help in knowing who is financing what, because that government, it's not always a clear cut to say government is financing this item and the insurance will cover this next item. Sometimes you find it combined at the service delivery level. And as an insurance, we want to pay for what is not covered. We don't want to double pay. If your HR is paid for by the government, why should I pay for it? With using my 14% while you are spending 50%. So I think ABC, if it was good to also, as part of the asking questions, who is funding what, that question is not yet answered. Even now that we are trying to cost benefit package, because we want to make sure that we are not double putting burden on either government or the insurance or hospitals, because they need to get 100% from whatever the source, whether government, donors, or the insurance. How can that be fair? I think that's the question of adding that extra question. Not only know how much does it cost, but where are the resources coming from? I think we have this question not answered yet. Thank you.
Yeah, the benefit of coming last. So yeah, I think maybe a context for Malawi. So we are pre-tax and donor financed, and then who major service providers for the tax financing and donor. So government provision, and then church-based faith organization. So for the government provision, there's no provider payment framework. So line item budget based mostly. But for the faith-based fee for service and some form of DRG. So yeah, so I think that brings me to an important challenge, definitional challenge we've been grappling. So I think from the presentation that someone made, Claire would see that where the health benefit packages arrived, including our earlier iterations of the packages now, it was really difficult to divorce the systems inside the packages. And so you arrive at an estimate of the package, but when you come to the time to do the strategy, then you need to find a way to remove the systems inside the package. So, yeah, so in the most recent iterations, for example, we grappled with defining the package itself. What should be the yeah, so most I think that we've tackled through. So I have colleagues here, Atamandik and Lalit. Yeah, so we've tackled through one first structuring the health system around it. So the bottleneck access, the system, divorcing service delivery, and that comes to another question I think that came up around how to treat preventive health services. So yeah, service delivery, putting it aside, and then think about almost a two-stage and then later iterative prioritization. So define the package, removing anything that could fit into the building blocks. Okay. So then mostly you're left with commodities, and then supplies and diagnostics going into the health benefit package. And I think that's how also we shifted from essential services or essential health package to adopt something like close to health benefit package. So that we couldn't say this is something we can guarantee as entitlement. And I think that's also the other. So this resolves the issue, for example, do you prioritize a system around the package after you've arrived at it, or it's a serious practical question, because if you arrive at the package and then you try to configure the rest of the systems around the package, you run another risk. What do you do with excess supply, which is already invested in? Yeah, so mostly in the context of Malawi, I think that's been resolved by thinking about the health benefit package in the broader health systems logic, and locating the health benefit package as a subset of the essential of the service delivery building block. And then again, how do you treat the programs? Because these are the troublemakers. So we've also said we think about first of all integrated service delivery, and so it's the systems for the service delivery are then jointly optimized, so to deliver the service. So you take out any systems from all the programs. So you ask, if you take out the systems from HIVs, what remains? So what goes into the health benefit package is HIVs minus the building blocks. So you do that with all the programs. So yeah, it's not a neat space, but we think that it provides a convenient way, a bit of iterative optimization process. You optimize the health benefit package as so using cost effectiveness, for example, estimates, and a bit of constraining, for example, around some quantitative measures, say human resource, which could, and later on, as you say, apply criteria analysis, you arrive at, as the previous commenters, some huge costs, because as you bring clinicians, they say this must be in when you already excluded, but it still provides a convenient starting point in that sense. Yeah, so I think the second issue then becomes who should, besides the technical process, who should be on the table to decide the package. So in our context, although we start from cost effectiveness analysis, mostly traditionally with jointly with University of York, but then the final package is a consequence of working with clinicians at all the levels, defining level-specific packages. Yeah, and the costs. So in that sense, we eliminate many of the complications, because then or to arrive at a cost, then mostly you then can work with cost estimates from central medical stores, for example, in our context, as a starting point. They are a monopoly supplier, but then of course the church-based also can source from other service providers. So we have another process for negotiation of the cost with So at least you have two major sources for the unit cost for the benefit package.
Thanks.
Yeah, I think
Is that,
me.
you have one final point?
Yes, maybe the last one, then earmarking. So how do you treat earmarked and earmarked funding, especially when the back of the essential health package that we arrive at would constitute HIVs, and in practice, it's not money that's really available. It's locked. It's locked. So if, for example, you arrive at a package costing $20 per capita, maybe what you can move, you can allocate practically there, maybe it's 40%, 30%. And then when you think about it, maybe half of the cost from government is HR. So it's still what's available to move around to in the prioritization process. It's just a handful. So how will you create those constraints? Because in the end, it's the prioritization, the optimization is not the same thing. Yeah, so.
Excellent. Thanks very much, Dominic. So now we have about 12 minutes for questions. So over to you in the audience. Yes.
Thank you very much, the presenter and the panelists. So three things. One is like sort of like a comment and a couple of general questions. So I think Regis was the one you mentioned that there were a couple of issues. One about, and I think it's what we need to all think about. Can we get the cost of things like human resource infrastructure that is sometimes paid as a compulsion, right? You must pay it out of costing, program costing. It's just an open question because sometimes those are the areas that really causes the confusion for policymakers. You say this is the cost to deliver these services, but then it's also paying salaries, and somehow those salaries are integrated into those costs. So would it make sense to start thinking about how we can begin to have 3 levels of cost or 2 levels, that this is the cost of delivering this service, but there are some, let's call them quasi-fixed, fixed and quasi-fixed costs that you know you have to pay and you're already paying, which are salaries, and you need to maintain or provide infrastructure. The second part is also regarding, was also mentioned by the panelists about costing, not what it should be, but what it is. So in costing benefit packages, how did we bring in the issue initially raised by Robert, standards and quality into that? So do we cost based on what we expect standards to be? So for virtually every program, they have this set of standards and things that will guarantee quality. And sometimes they are very far from the reality. And according to, and when you do the ABC costing, you are costing what is as opposed to what should be. And the cost, and it's really cost different. So how is that, how does that apply in practical reality in when you're paying your benefit package? Then lastly, it's for the audience really, does anyone have a very clear example where because they costed a benefit package, you got more premium? They say, oh, that's the cost. They got more premium or you got more health budget. Thank you.
That was 3 questions for the price of 1. Let's collect a couple of other questions. Yes, and then yes.
Hi, thanks very much. It's fascinating to hear from you. My question is in reference to the comment about level-specific services, which is obviously linked to cost effectiveness as well. And you can see this approach being used certainly in South Africa. We have an essential medicines list, which is by level of care, which feeds into a set of standard treatment guidelines as well. One of the challenges with that, though, is building continuity of care for patients and taking that patient-centered approach and trying to understand how they are expected to experience it. Because where there are challenges, it brings up huge costs from a patient perspective. So I wondered if you had any experiences around benefits and linking them across levels of care from any of your countries.
Thank you. You had your hand up. Yes.
Yeah, my question is about financing normative versus real costs. An argument for financing maybe, for example, a provider who should be spending 20 minutes but is spending 11 minutes is that you want to even if the provider is currently spending 11 minutes with the patient, eventually you want to get the provider to spend 20 minutes with the patient because of efficiency and because it's shown to demand creation and et cetera. So by reducing the funding, you would be taking that opportunity away. And so in a sense of not spending what it should be, you might be limiting the opportunity for growth and capacity building. Yeah, I'll leave it there.
Excellent. And Gerald, one last question, quickly.
Thank you. My name is Gerald from Uganda, and my question is about capacity building and capacity to do this costing. I think it has come through from most speakers. So in a situation where you have a ministry or a public agency where that capacity is not there, how do you go about building that? Because you're going to need this costing and you are going to need it updated frequently, considering changes in costs and inflation. Thank you.
Excellent, thank you. So what I'm going to do now is that I'm going to ask each of our panelists to be very brief and perhaps to tackle not all the questions, but one at a time for about a couple of minutes, and I'll be strictly enforcing time. And I'm going to start with Dr. Solomon.
Okay, thank you. I think I'll try to address the last question around capacity building. I think this is an important aspect, and there is, recent movement around that. And one way is by establishing, health technology assessment units within the Ministry of Health, or within the universities that could support the Ministry of Health. And such activities is gaining traction. I think recently Africa CDC is also, taking this agenda and trying to develop that capacity within countries. To come to a specific situation about Ethiopia, and there was the Ministry of Health at one time discussed with partners, and they developed this the Disease Control Priorities Ethiopia project, where they trained experts on economic evaluation and costing aspects at master's and PhD level to create a health economics unit within the Ministry of Health. This is one kind of capacity building activity that could be replicated in other countries as well. Now, this health economics unit is trying to develop into health technology assessment within the premises of the Ministry of Health within Ethiopia, and we need such kind of exercises in other countries as well, which is required for both prior setting, costing, and other aspects. Once the benefit package is developed, there is this ongoing need, because new technologies will continue coming that should be adapted within countries, and health technology assessment could help in that regard. Yeah.
Thank you, Solomon.
Hello. Okay, thank you very much for the valuable questions and comments. Let me address a couple of questions. First, with regard to the indirect or the shared costs like HR, personnel, infrastructure, utilities, and the like. It's that what I was saying is in our country, the practice is mostly on focused on when we do costing consumables or the others, okay, drug and supply and the other, because in Ethiopia, personnel, the infrastructure, and the other are subsidized or paid by the government. Okay, so it focused on that one. But the other approach, what we are doing is we try to know the true cost, okay, including everything. Okay, that's why that's the starting point. If we have the true cost or the actual cost of a given service provision, so anyone can choose from that, okay, which type of components shall be financed by whom, okay, that could be the starting point. And then also we can reduce fragmentation and as well as duplication of effort. Once we have as a master list, so anyone can choose from that, okay. And the other one is with regard to normative versus the actual, we follow a normative approach actually, okay? The standard treatment guideline, we try to adopt that one. But my recommendation from our practice is let's try to marry between, okay, doing that, a normative approach as well as understanding the actual situation, okay? So we try to see also the expenditure trend, okay? How it looks like in the pattern, okay, the expenditure at the facility level by level of care and the like. And we see also the normative approach, and we try to marry between the two. But that the starting point is the standard guide of treatment because it shall not be compromised. Then, as my colleague from Rwanda said, yes, it depends on the capacity of the insurance, but the premium collection and whatever it is, okay? So, but for us, while we do the health benefit package development, so we try to look into in different ways. For instance, let's try to see all the package, okay, that emerged from the essential health service package of Ethiopia. And then we try to reprioritize based on the insurance, and then based on the cost effectiveness analysis and financial risk protection or other aspects, okay? There are 5 more criteria, and we try to sort it, okay? Based on the high level of meaning priority. And so based on the physical space or budgetary room of the insurance, so we'll reprioritize what to be included in the benefit package, okay? Because for Ethiopia, there are also other aspects. We call it exempted health service that was free for everyone, okay? So it depends on what type of service can be part of the insurance package, what shall be included in the exempted health service, and which shall be also paid out of pocket and the like. So the Ministry of Health of Ethiopia look into the entire envelope and try to see in that.
Sorry to cut a bit, Tesfa. I apologize for that. Regis.
Thank you. I think I have to choose between the question I answer to, given the time limitation. On the cost of HRM and infrastructure, I think what I was talking about was based on community-based health insurance, which is contracting only public health facilities. So those elements were excluded from the costing because we knew they were covered by the government. But we have another process for another insurance that we manage, which is a social health insurance that started mainly with government employees, later on onboarded private sector. They contract private operators, and you can't tell them, I don't count for infrastructure. So we did both a bottom up and top down. So we accounted for the whole building, the whole human resources, and allocated to services according to the utilization. And you realize that big hospitals that are required to have, let's say, 50-bed capacity private hospital, they will have a big overhead that everyone is trying to become a hospital because overhead is so big. And you comply with that requirement, but we fight around keeping doing the primary types of care because it's like an investment in infrastructure. You get what you want, and you get more money for doing almost basic services. Second question is about standard and quality. Yes, and it will be the last. Standard and standard of care or quality. I think it's a chicken and egg discussion. If I give you more money, will you be spending more time on the patient? I don't think so, because I think the discussion is around who pays for what, and we do it because we are discussing against the government that is spending 50% of that. So we tell them first train enough, first have the infrastructures, then deliver the service according to the standard, then we adjust accordingly. But we can't advance you because we didn't have advance extra payments to cover for what should be as the service.
Thank you, Regis. Dominique?
Yeah, I'll cover the question around level specific benefit packages. Yeah, so I think what I didn't tackle was the fact that we prioritize. We've moved from prioritization of, let's say, an average package which previously would be pro primary care, because of is when it's based on cost effectiveness estimates, to optimizing at levels of care. So we build a package, optimize it at a relevant level, and then think about it, build then the probabilities of referring to the next level. And so optimize and then build again. So that's kind of the yeah. So that allows that when so that's aligned more with the concept of UHC, because when the patient enters through the process, if care, so also cost effectiveness depends on level. So in that sense, you want to take the patient through until, but also in that sense, it allows individuals to interact with the systems up to its capacity in terms of the supplies, but not human resource. So what we do in that sense, not human resource and for example, diagnostic capacity, because it's already available. So you're not going to, that's tied now to an exemption, to an access exemption framework, where the policy is to allow access to the HR and increase the infrastructure and all the building blocks, because you cannot exclude before, you cannot determine whether it's HBP service or not before they've already used up the systems. They've already come to the consultation. So mostly that's kind of that's the idea around optimizing the building blocks, the rest of the building blocks jointly, and then iterate with the benefit package as a subset of service delivery. So most, I think that's
Thank you.
yeah.
Thank you, Dominique, for these final words. Thank you very much indeed. And I want to take this opportunity to thank our panelists here for a really rich discussion. And I believe now it's a break. Okay, thank you. So let's clap our hands.
So we'd like to invite you for some coffee and a little snacks, and then please don't forget to come back. We have one more panel and lots of interesting connections again between methods and costing methods and results and policy. Thank you.
So what we want to talk about in this last session is we really just want to explore why it is that some of the results that we produce from our costing studies don't get used as extensively as we hope to as practitioners, and to try and understand a bit better what some of the barriers are to data use, but also what some of the enablers are which encourage the use of our costing data. So just a brief overview of my presentation. I'll start off with a few scene setting slides. And after that, we'll unpack 4 real-life examples of costing studies, how those unfolded, and whether or not the data was used, as far as we know, and what some of the barriers and enablers were that facilitated that use. After that, we are going to attempt to organize some of these barriers and enablers and see if we can put them in categories or buckets to help us structure our thinking around some of these issues. And lastly, the purpose of the presentation really is just to provide a platform for discussants to start a rich discussion around some of these issues. So we submit that most countries at this point in time, certainly in the low income and lower middle income bracket, don't really have in-country systems which can routinely generate accurate and sufficiently disaggregated unit costs to inform planning and decision-making. And as a result, traditionally or historically, there's been a high dependence on large once-off costing studies, which are typically resource intensive. And we heard about that earlier today from some of the other participants and discussants. The second contextual issue that I want to just draw to your attention is the fact that many of our priority diseases are still vertically funded. But we are moving into an era where that external funding is either flatlining or to some extent decreasing as some countries move up in terms of their income classification. And this builds pressure on those countries to start thinking more seriously about transitioning to more robust in-country systems which can routinely generate some of these costs and some of this data. And there's a need to reduce this dependency on externally funded large once-off costing studies to inform decision-making in countries. So it's in the context of this transition that we want to tackle some of these issues and understand better what some of these barriers and enablers are, because one might argue that these barriers, or understanding these barriers and these enablers, needs to inform the development of these in-country systems so that we don't replicate some of the problems that we have experienced with the once-off costing studies in country. So we had the benefit of doing a landscaping around costing tools and costing practices in a couple of East African countries over the last 2 or 3 years. And part of that landscaping allowed us to interview a number of government officials, both at national level, but also at subnational level. And some of the questions we asked them about is why they don't use some of the costing data that we had produced. And so I just want to qualify some of these statements and observations in the sense that these are not the result of some extensive qualitative study. They're simply observations that emerge from key informant interviews. But some of the things that people said is that there's the lack of standardized and government-endorsed unit costs in countries. And I think this often happens in countries where there's lots of research that's unfolding. Quite often it's focused on the priority diseases. But at the end of the day, people are faced with unit costs for the same service which differ. And they might differ because the methodologies differ, the scope of the costs included differ, but nevertheless, people are left wondering which costs they should use because, you know, it's confusing. The outputs from a lot of these costing studies are not fully owned by government or validated by government. As such, they do not find their way into sort of budget guidelines that are issued at the start of the budgeting cycle. And therefore, nobody uses them, even if the underlying study was perfectly good and the results are perfectly robust. And something we've seen a lot, and I'm guilty of the same practice, is that we don't often translate our costing study results into a language or into a format which government can use directly in their budgeting and planning systems. And this is often just about reshaping and presenting data differently. So if you're a budgeting official and I present you with an economic unit cost, it's going to be very difficult to integrate the one into the other. And some of the speakers mentioned that earlier today. And to some extent, there's a historical mistrust among some of the decision makers when studies have not been driven by government. In other words, if partners have requested or initiated a study, which may be a perfectly good study, but if government hasn't been sufficiently involved and hasn't prioritized the study, there may be some mistrust of those results. So one of the questions we're going to be asking the discussants later today or this morning is, in which stage of the planning cycle is costing data most often used, or where the biggest gaps are for costing data for decision-making and planning? And so very briefly, it's a simple planning cycle. Stage 1 deals with policy formulation and strategic planning and prioritization, and the establishment of high-level resource envelopes, typically by sector, occasionally for interventions in the sector. Stage 2 talks about the detailed planning and budgeting and allocating the envelope to specific interventions and activities within that sector. Stage 3 is about budget execution and the performance management of programs and expenditure tracking and so forth. And lastly, the stage 4 is really just where a lot of our costing studies happen in order to generate evidence to inform the other stages of the planning cycle. So I'm simply presenting this so that when discussants talk about the planning cycle, then this is what they're referring to. So I just wanted to briefly describe 4 real-life examples of some studies that we either participated in or know about, and express some views on the outcomes from those and what some of the barriers and enablers were. And the first one refers to an innovative youth and childcare initiative, which the Department of Social Development wanted to implement a few years ago in South Africa. And The project required that we did a detailed ingredients-based costing, which was largely based on the implementation plan for that intervention, but also using expenditure reports and informant interviews to inform that process. Importantly, it included a budget impact analysis, which explored a number of different scenarios. And the object of the study was to mobilize additional resources to allow provinces to scale up that intervention from a sort of pilot phase into a fully implemented province-wide initiative. And obviously, at the end of the day, you also want this sort of intervention to be earmarked in the medium-term expenditure framework so that that allocation gets carried forward into the subsequent years. So broadly, this had very positive outcome in the sense that there was a significant allocation from Treasury over and above the allocation to provinces to allow the provinces to scale up this intervention. The costing format was aligned with that implementation plan and with the budget line items that the government typically uses, and that made it very easy for them to complete their request. And lastly, and maybe this was the differentiator, is that there was strong political support and drive for this intervention from the very start. And that made it very easy to get government's buy-in and get things done. So the second study I want to refer to briefly is a comprehensive costing study we did in Zambia on routine immunization services and introduction of new vaccines. This was quite an extensive study. We collected data from over 50 facilities, and we did extensive regression analysis and presented quite a comprehensive and substantial report at the end of this. And the objectives were to inform decision-making and planning, and largely the allocation of additional resources to facilitate the scale-up from current coverage levels to higher coverage levels within immunization. And we provided costs on the introduction of new vaccines as well. So the uptake of this information and these results was not as good as we'd hoped. We can't point clearly to any decisions or plans that were amended or changed or made as a result of this information. And so it's a little bit disappointing when that happens after so much effort. One of the reasons I think was mentioned earlier today about the fact that the data got published quite a long time after we actually gathered the data, right? So there's this big time gap between when you actually collect the data and when you actually make it available. And people consider it sufficiently robust to release and so forth. So this was not very satisfying, but we were given the opportunity to go back to districts and to in fact present the same data to district level managers. And that was a very interesting experience. And the first thing we learned is that they had never heard of the study or seen the results. So dissemination was a real problem in the sense that it got stuck at the national level and didn't find its way down. And this is an issue when actually the budget formulation process starts at the district. So they never got the data to use it. But what was nice is when we presented it to them, there was some really rich discussion between the various district managers about the unit costs, why some unit costs were higher in some district than others, etc. And even from that perspective, it was then valuable. The third piece of work that we are involved in, and mainly Stephen, who's here in the audience, and Mr. Koza can speak to some of this a bit later as well, is a set of support activities to support the formulation of the conditional grant funding request by the provinces in South Africa. And the nature of the work involves providing provinces with detailed and standardized planning tools and benchmark input costs and guidelines, and also supporting the national level with additional analysis of the provincial requests that have come through. And one key objective was to try and standardize these requests to facilitate the comparisons and further analysis. And I think generally speaking, the results from this sort of work have been positive in the sense that the quality of those requests has improved significantly. And they're standardized, which makes it possible to more easily consolidate those requests and conduct cross-provincial analysis, highlight outliers, and deal with some of the variance between the provinces. And the analysis has also sparked additional requests for similar type of work. And this has enhanced those submissions quite significantly. Again, a key enabler here was that this is supported and driven largely by government, even though the actual work is being funded by an external partner. And the last example is really just a general comment about the costing work we do to inform investment cases and the extent to which that work actually gets incorporated into NSPs and Global Fund and other funding requests. And I know that there are many countries that are an exception to the rule, but quite often we find that these investment cases generate perfectly good results, but it's quite hard to actually see the recommended scenarios of impactful interventions reflected in the NSP or in the allocation of government budgets thereafter. And the same can also be said, I suppose, for some of the funding requests, which are then based on the NSP. So the linkage starts to weaken. One of the reasons for that is that we've seen more and more now that countries are very late in starting these processes. And then we see the investment case, the EPI modeling, the NSP, and the Global Fund funding request all happening in the same 3 months before the deadline. And so the opportunity to really go through an iterative process to incorporate the results from the modeling and the investment case into the NSP is eroded. And that's unfortunate because obviously there's some really good results out there which just don't get used. So colleagues, that was the last example. And the question then is it possible to start organizing some of these barriers and enablers into sort of categories that can help to structure our thinking? And so we've proposed a few categories here, and we're not suggesting that this is an exhaustive list, but nevertheless, in no order of priority, we suggest that if the intervention that you're costing is not a political priority, then as a practitioner, you need to be cognizant of that and probably be realistic about the extent to which that data will in fact be used. Obviously, it's much better if you get invited to cost an intervention, which is a priority, and you kind of know that the data is being needed and looked for. The capacity of human resources and of the institution to actually take the results, to unpack them and to repackage them and make them suitable and useful for budgeting is typically limited in most countries. And arguably, we as practitioners should probably get better at repackaging our results and acknowledging the formats in which government actually needs the information. The third item that's of real interest to me is the culture that exists in an institution. So if the culture in an institution is to use evidence to make decisions and plan, then that's a receptive culture. But if you're in an environment where the culture is to take last year's budget and add 10%, and that's how the budget systems and the rules and norms have been set up, it's very difficult to shift and change that, certainly in the short term. It's also important to acknowledge the fiscal realities. This was mentioned earlier today as well. In many country health budgets, the budgets are still line item based budgets, and human resources, commodities, and laboratory costs typically consume anywhere between 65 and 85% of the budget. So the budgeting people are left with very little discretionary space in which to make decisions and prioritize. And so if you present a comprehensive unit cost for service provision, it's very hard to translate that into prioritizing within that discretionary space. Ownership of and trusted evidence. I think we touched on this a bit earlier, so I won't spend any time on this, but it's critically important to get the buy-in of government and key stakeholders, even if they're non-governmental, in supporting that process and understanding the output. In evidence dissemination, we touched on just now, I think it is quite often the case that we have our last meeting, we disseminate to the steering committee, we issue a report, and that's kind of where it stops. Very seldom is there a clear strategy to disseminate this information to lower levels in the system. But we know that in many countries, there's an active process of devolution of power to districts and lower down for budgeting purposes and for budget execution and program implementation. So it's important to make sure that the data gets disseminated. Then at the district level, we've also discovered that the decision-making space there is very limited. So the same district managers we spoke to in Zambia told us that the human resource budget line item is centrally budgeted for. So they had no control over determining how many people they could or shouldn't employ or the salary bill. They could apply for additional staff, but they were not allowed or couldn't influence that budget line item. Vehicles and transport are often controlled at a higher level. And so it leaves the decision makers at the district level again with very little discretionary funding. One hopes this changes over time. We listened to the direct facility financing presentation yesterday, which highlighted that there are some real benefits to that. And as that happens, costing data will become more useful to them. But right now, for many people, the way we present it again isn't that useful. And of course, the relevance and the utility of evidence, really, this is about matching what we produced with what the real need is. And this speaks to some of the miscommunication that happens when needs are poorly articulated and interpreted by others as a particular methodology. In costing study, you finish the costing study, you present the results, and people say, well, that's not exactly what we wanted, putting it in plain language. But that does happen, and this is about making sure that the one matches the other. Colleagues, this next slide is just starting to touch on what one might do in order to respond to these same constraints or barriers. Now, I'm actually not going to spend much time on this slide because I think this is exactly what the discussants can talk to. When they spend a bit of time responding to some of the questions that we pose. We talked briefly about the fact that if we don't have political prioritization of the intervention, then you need to be realistic about who's going to use your data. There's not much you can do about it in the short term. Human resource capacity, the need to develop this capacity within government to unpack, repackage, and disseminate the data to the people that are actually compiling the budgets is really important. Organizational culture is also difficult to change in the short term. We know that it takes years. Many countries have started that process of moving from sort of line item type budgeting to activity-based budgeting and so forth. But again, in the short term, very hard to manage. And the same goes for some of those other barriers. And the one we can do a lot about is the dissemination. I think we could get a lot better at including dissemination strategies in our scopes of work and making sure that those processes unfold and emphasize the importance of those. We can also probably get a lot better at involving stakeholders early on in our processes and making absolutely sure that people understand the methodology, how the unit costs have been compiled and what they actually mean, to make sure that government validates the results and owns those results and is happy to disseminate them. And then lastly, really important to invest a significant amount of effort upfront and stress testing the use case for the work that we want to do to make sure that what we produce does in fact match what it is that the stakeholders need for their decision-making processes. Good. Thank you very much for listening to me. And I'm going to hand you back to Francis to moderate the session with the discussants. Thank you.
Thank you very much, Carl, for that excellent presentation. So right now we want to invite a group of experts who are from countries where we're trying to foster the use of costing data for decision making. So let us, please, the panelists, could you move up to the stage over there while we continue the discussion? Yes, absolutely. So thank you very much, Carl, once again for that presentation. And thank you so much to our distinguished panelists for agreeing to being on this panel. And we must also thank the audience who have stayed with us from the time that we started this panel or this session. So I would like to introduce to us the panelists who will be here today. Please, could we get their profiles up on the screen, please? Thank you. So the first person I would like to introduce is Nthabiseng Kosa, who is from the South Africa Ministry of Health. Please let us appreciate him. And also with us, we have Atamandike Chinkwanda, who is a health economist from Ministry of Health in Malawi. And then finally, we have Dr. Obwe, who is from the Nigeria Primary Healthcare Agency with us today. Great. So a lot of the conversations that have happened today have been looking at why is costing data important? And I think it's become established knowledge here that it's very important, from conversations around using it for prioritization in the face of scarce resources, improving efficiencies and qualities, and also being good for decision-making, day-to-day decision-making and policy-making, and a whole range of other benefits that have been identified today. But I think the conversation for this afternoon, both with the panelists as well as the audience here, is how do we move from good to do to actual practice, where we're actually doing this in an institutionalized manner that is leading to performance improvements and improvement in health outcomes in the communities and the people that we have to serve. So my first question to the panelists is this: could you share with us, from your rich country experience of working as a policy maker to effect change and policy reforms, where exactly in the policy process, according to the presentation that Carl made earlier, where exactly in the policy cycle should costing data be utilized most effectively? So we can start from.
Okay, thanks, Francis. From my experience, I will address it from the ideal and then from the practical. Ideally, you would want to use the costing data across the whole planning and budgeting cycle. You would like to use it, for instance, when you are discussing with your Minister of Finance colleagues, your needs as a health sector, very, very important. But beyond that, you must also do your own homework as the health sector stakeholders. For instance, there was a session on the health benefit package. You also need to inform that using the costs that the realistic costs that you are going to incur. And again, when it comes to actual execution and the performance monitoring, you also need the cost data. So in short, in an ideal situation, you want to use the data across the whole cycle. But as the previous discussants had indicated, there's a cost to getting the data. Plus also, you must also understand your context. If you are to prioritize between the broader policy formulation, your interactions with the MOF, or within the in making decisions, allocation decisions within the health sector, or at the budget execution. So I think that really depends on the context of your country. Are you going to get much value if you use that data to engage the Minister of Finance, for instance? From our experience, engaging with the Minister of Finance using cost data, while it is important, it may not add much value because of the political nature of the decisions that they must make at that level, at the Minister of Finance level. It's not just about the evidence. Yes, if you give them the evidence, they will have food for thought, but eventually there's a political prioritization which we must answer to. Plus also, there are several other things. For instance, politicians want to get the results there and then, so they would love to invest in that. So whilst it is important, it may not be the best way if you are to choose one. I would prefer to use it to make decisions amongst the health sector stakeholders, like within sector allocations. Where do we invest more, and what will be the costs for doing that? So, in brief, I would prefer the within sector budget formulation planning to use the cost data. Thanks.
Thank you very much, Atamandike, for that response. So I'm moving over to Dr. Obe. Atamandike raised some issues around, the importance of using this information within the Ministry of Health, but he also emphasized engaging ministries of finance, as well as some challenges with being able to effectively engage them. So could you share experience in that regard? There was an interesting conversation that came up around how does Ministry of Finance set envelopes? So could you maybe perhaps reflect on that a bit as you
Thank you very much for the opportunity. I think the costing is required at every point of planning, but the how critical it is in terms of actual practice for government funds allocation varies at the various stages. So regarding the Ministry of Finance, I think the biggest challenge there is when you come to them with costing data, which methodology they understand and is scientifically done, it gets a listening ear. But from experience, it really does not make any difference if there's no commensurate increase or improvement in the total fiscal budget available within the country. And so in Nigeria, we started about a year plus 2 years ago, tried to do some generate a case study for primary healthcare investment to reimagine primary healthcare. And we did do some extensive costing, and this is what we need to invest, right? And the Ministry of Finance, they were willing to listen, but the point was that where are we going to get the money from? Nothing new is happening. And the challenge for the health sector is that even when there are new opportunities, the health sector is not part of the conversation. So in Nigeria, fuel subsidy has been removed. There are lots of conversations going on about where that money should go. And the health sector is not in that conversation. So by the time the health sector gets into that conversation, decisions have been made and therefore almost impossible to go. And the other thing that sort of influences the Ministry of Finance in terms of whether they appreciate or use your costing data or not is because in reality, they make decisions on other parameters, which is beyond the health sector. They're making decisions for the entire national economy. And so they look at how much you've spent last time and how much you're asking for. So health comes and asks for money, and sometimes they say, do you have the absorptive capacity? We gave you such amount last year, and at the end of the year, you still have this amount left. And they don't appreciate the fact that sometimes in health, monies are siloed. So money for tertiary care, money for primary care are sort of siloed, and it's not convenient to move this money around. So, but for them, it's one health, so it's one budget. So if you still have money in respect of what it's meant for, it means you're not using your money effectively. And that impacts on when you come asking, even whether it's based on costing or not. But I think when we go to looking at possibly what can be done, we could look at some aspects that could influence that. But just quickly, where I think the costing data really should make the most impact is in the part of budgeting and budget allocation within the health sector. After your envelope has been fixed by the finance and provided you that you have this fund, then how do you best utilize it? And I think that's really the most critical part of costing, because then you could actually look at value for money in terms of what are you costing, what is it for? But the only challenge is that you can't do this in an isolated manner. You can't just bring the cost of HIV or family planning and say, yeah, that's the cost, give them the money. You need to come with the cost of everything that needs to be done and begin to look at relatively where are the synergies and which is more cost effective for you to deliver on before you take those decisions. But then you have your envelope already. So then decision making, it can be more finite and more concretized based on costing and what you spend money on, as opposed to where you have little control about where the total envelope would be.
Thank you so much. That's a fantastic insight. And I would like to move on very quickly to Intabisang from South Africa. Do you have a similar experience, or are there differences in your experience in South Africa?
Thank you. Thanks for the opportunity to participate. Specifically to your question, there aren't any differences in terms of the experience in South Africa. The only reference I would like to make, I think, in terms of the purpose of discussion, is that the role that I play in the ministry is that of managing the HIV and AIDS program, HIV and AIDS and TB program, and not necessarily health generally. That's one. Two, I think the by training, I'm not a health economist. So I studied accounting and in the realm of financial management for financing programs. Three is that, you see, once you've got an advantage like that where you are able to, the third point I wanted to highlight is that the positioning in terms of where I currently operate in the department is not being in finance. So even if I'm finance trained, I'm not in the finance unit, I'm actually in the program. So proximity to program or what you're financing becomes an advantage because you get to then grasp and understand what is it, what the outputs are, what are you intending to achieve. If it's HIV and AIDS program, that's what we're seeking to get to. So the challenge that I always get to hear when we interact in forums like this is that we seem to be siloed. Yesterday I had a discussion, I participated in a discussion with ALM where we're saying, the difference between Ministry of Finance and Health. What language does finance want to hear and what language does health want to hear from finance? And I think from where I sit, the advantage is that I'm able to talk both languages on the finance side and on the program and financing side. The specific to your question on the issue around where do unit costs, where the costing data, when is it applicable and when is it required? I would say from Carl's presentation on the planning cycle, it's required throughout the cycle. But mostly we tend to get to use that information when we are doing, for instance, budget bids or requests for budgets or finance from the Ministry of Finance and all that. But where it actually starts is in the costing of programs. And sitting this morning, I was thinking that maybe one thing that we probably need to and not necessarily on the HIV and AIDS side, which is the area that I operate in, but generally in health, I think we can never distance ourselves from the need of having to do a costing for health programs in terms of health outputs, whatever the targets and what aspirations of a country are in terms of the health outcomes. That needs to be costed. And the issue then that we then have to get to establish is the coverage rate. At what coverage rate are we based, how far are we from the targets in terms of what we want to achieve? For instance, in South Africa, as you know, the genesis of our HIV program, which is said to be the biggest in the world, is that it did not start there, but it's driven by the demand because we know the impact in terms of what will happen if we don't do what needs to be done. So even if you actually get to have a resource constrained kind of situation, but you need this costed kind of interventions and programs for you to make a budget bid or an advocacy statement to the financiers to say the benefit out of in terms of investing this at this rate would give you this level of coverage, and the benefits out of it is this outcomes in terms of health. Failure to do that will give you a burden in the health system that you have a very sick community that will demand inpatient care. And one way or the other, whatever they don't want to invest here now, in 10 years' time, you've got to come back and invest it in health because the demands will dictate that you've got to then respond to that kind of thing. So I'm not sure if I've been able to actually give you an exact answer in terms of what I think, but those are my reflections in terms of what I think costing data assists evidence in terms of costing data assists in program in health. Thanks.
Thank you so much, Nthabiseng. I think a reoccurring theme across the three speakers or the three panelists is that health sector actors, we need to get our house in order first before we can actually approach the Ministry of Finance. And thank you so much for bringing up that very important aspect of saying that health economics language is not necessarily the same as Ministry of Finance language, because sometimes we think, oh, they are economists too, they should understand, but we need to find a way to present this information in a way that aligns with their own thinking, their own language, and the way they do things. So moving on very quickly, because we want to make sure that we have an extensive discussion with the audience. I'll put out this last question to the panelists, and please try to keep it below 2 minutes so that we can have enough time to interact with the audience. So this question is in 2 parts. The first one is, what are those factors that limit the use of costing data in setting priorities, especially in a decentralized setting? So many people that spoke earlier have spoken about the fact that there are federal systems, but when you take it down to the district level and the facility level where actions happen, what are those challenges? What are those obstacles? And then finally, for these obstacles that you're speaking about, what can we do? How do we overcome them? What are the actions that we need to take? So I would like to start with you, Nthabiseng, because you already started having that discussion, and then we'll move down.
Okay, I think on the issue around obstacles, we probably, I mean, ideally, we probably would want to have planning and budget execution happen at the lowest level. But practically, there are limitations that goes with that. Firstly, is that it depends on the current of, I mean, the systems that you have in place, be it the financial management systems, the patient data level data information that you have, or the capacity in terms of individuals that you have on the system. That's one. Two is the issue around the level of autonomy that the smallest unit has. So for instance, South Africa, how we implement the HIV/AIDS program is that funding gets mobilized at national level, but then we transfer all the funds, 100%, to the provinces, and subsequently provinces work with districts and then facilities. But the span of control in terms of monitoring and ensuring that you hold people accountable to that becomes weak if you don't have tools to be able to do that. So you then have to then develop, what we did was develop tools in terms of planning, like business planning tools. Then secondly, we developed what you call a unit cost database, and that we update on regular basis, so that we force standardization, that whoever at whatever level that we plan, we actually are planning almost the figures that you get out would probably be the same, because you have standardized at least up or on 2 or 3 levels. Thirdly is that then you got to strengthen the monitoring element part of it, because then what then happens is you need to, for instance, we can tell you how much it costs per patient per annum on treatment, but at costing level and planning level. But then you've got to then come back and do a retrospective analysis that looks at expenditure now. How much did you actually get to spend per patient per annum versus what you had at the planning level? And I must say that even if in a system where you think that is perfect, you without having to do this oversight and consistent monitoring, that actually wanes off. So you've got to find a way to be very deliberate in dictating from national or higher level side in terms of what are the non-negotiables in the full spectrum and value chain to ensure that that happens. So yeah, let me pack it there for interest of time.
Thank you so much for that excellent response, Dr. Olwe.
Thank you very much again. I think I would just probably look at it again from the policy part about the challenges and what can be done. And I think Carl's presentation spoke a lot to many of these, but just putting it all together, I think the first is really the availability of the costing data in terms of how recent was it, the timeliness. So decisions are about to be made, and then you need the costing data. And if it's such that you have to start the costing at that time, usually there's no time to do a good job and have the cost ready to make those decisions. And that's also impacting on the capacity of the people at the more decentralized level, the lower levels, to actually conduct the costing themselves. And I think that the next is also the ownership of the data, in terms of the culture of the data, or in terms of who did the costing, and how well aligned are this costing to the political views, right? Because if the politicians are talking about we don't have, like in Nigeria, so at the point, not now, it's better now. In the northern part, there was a lot of denial at the subnational level about the SN of malnutrition. So if the governor is saying there's no malnutrition here and you're bringing costing data for malnutrition, it's going to be spend more effort querying the data than actually looking at it and using that to influence budgetary allocation. Then lastly, is also the source of funding. So at the subnational level, particularly if the funding is from donor organizations, then it's easier because things are done and moved. But if it's from government, then that's really more peculiarities. Every region has peculiarities in terms of human resource, in terms of cost of commodities and all of that. And they want all of this reflected. And when this is not reflected, they tend to not to find the costing data quite useful. So in terms sort of addressing some of these things, it was interesting to hear from South Africa about the templates, whereby no matter how you do it, you all come up with the same result, because I think that's really a very viable solution. If at another opportunity, that could be looked at more closely, because there are actually two choices. One is either we find a way to simplify costing such that states, subnational, so states are like provinces, and districts can actually use the way that you plug in certain data and it gives them a cost, because most costing templates and methods are way too complex to be done routinely. The other way is to build established teams at the subnational level that have the capacity and they're able to routinely do cost either every year or every 2 years, and just maintain a database of costs that all you need to do is just check and maybe cover for inflationary trend that is ongoing at that point in time in the country. So those are some of the kind of things that could be done. At the more high level policy, because national has to guide all this one way or the other, particularly if the budget is coming centrally, is really to add two aspects to what we do when it comes to costing. And I think one of that is really not just the costing, but also the aspect of cost benefits analysis and cost effectiveness to what we cost. So we've cost this, we need to be able to demonstrate particularly that because we have costed this, and this gives you more benefit for the money than these other alternatives. So it takes a lot more work, but that's how you really make a difference. And that brings the part of the HTA coming in, the health technology asset, which most countries don't operate. But you see, this takes a lot of foundational building and lots of background work to get it to the point where it is seamless and you can use it. And nobody's patient enough to do all of that. So we end up costing, and it's not relevant to you simply because it's like, this is just a lot of talk. What you're telling me at the end of the day is that you need more money. I don't have it. So what do we do? Manage with what I can give you. This is your envelope. So go work it out. But if we can take the patience and time and get the right support to build these institutional capacities, costing teams at every level that can routinely cost, put in place HTAs and they do the background work and get lots of this data out there that you can pull from and show the benefits of every of the different strategies and packages we are delivering, as opposed to not doing anything or using other packages, then there's a stronger case to make of why that costing should be used, because it makes all the difference at the end of the day. Thank you.
Thank you very much, Dr. Obi. And finally, Atamandidi.
Thanks so much. Yeah, I would like to agree with the what my other panelists have said. From my perspective, if I'm, for instance, a district health manager, and you are coming with or must do costing data, first of all, I would want to know what is it for me. So I think that's the most important question. If I'm a district manager, because if costing remains divorced from the budgets that I get, or if it does not help me to make a better decision to get better health services or better health outcomes, then it remains an illusion, and it's something that I wouldn't be interested in. So I think that's the one of the major reasons why costing, especially in decentralized settings, is not taken seriously. The usefulness of it. What does it contribute to? Yeah. So yeah, and also. Yeah, also issues of autonomy. I think it was mentioned. If I do the costing, but then I can't make a decision over it to reallocate resources, then yeah, it's not useful to me. Yeah, sure.
Thank you so much, excellent panelists. And now we throw it to the floor for questions and contributions. David?
Yeah, maybe let me ask my question, then I'll pass it on. So there has been a discussion around ownership. And particularly in the morning, we also spoke about the fact that you have collaborated with a team to do costing. But the moment the numbers come out, they say, no, these numbers, we don't agree with them. And so one of the proposals Schultz made was collaboration. So you collaborated, but they don't agree with you on the numbers. I don't know whether you have any idea or suggestion as to how you would deal with that type of situation, because you end up now with numbers that you cannot utilize because the key stakeholders are disowning those numbers.
Thanks, David. So let's take the next couple of questions.
Is it better? Okay. Hi, I'm Refila from Hero. So my question is around dissemination. So Carl highlighted earlier that part of the problem from that inhibits government's uptake of costing studies is the problem of dissemination. So from the panelists, firstly, I'd like to understand from you is that which is the best platform actually to kind of release our costing studies to get government's attention. That's the first one, particularly if the government is not the commissioner of the costing study. And then my second question is, from the panelists, how would they like to receive this data? Is our academic articles working for them? Do they need our Excel sheets? What is the best way to help them understand the data easy or interpretation? Thank you.
Thank you so much. And I think we have one more question there for want of time, then we'll come back to the audience.
Hi, everyone. This is Emmanuel Drabel from Johns Hopkins University. My question relates to the concern around cherry picking costing data for policymaking. So do you think that in countries we need to have independent bodies like NICE or I don't know, ICER or the TAF's Center for Cost Effectiveness Analysis, like that would collect data, that would serve as a repository for costing data and help governments make decisions.
Thank you very much. So we'll go back to the panelists now. I think there are 3 key questions. I think we got it. So you can address anyone you want to address, be it on ownership, on how to disseminate and communicate with policymakers, as well as should there be a body driving this. So you can take 1 or 2 of the questions and then pass to the next.
Okay. I'll deal with the issue around dissemination, but I think it will one way or the other find its way to the first one of ownership. So my take is that the results, I mean, even before we do the study, the best way for me has been that it's easier when you already know, because I mean, as you commission, I mean, as you conceptualize a study, already you know what is it that you're trying to address or to find. Once you've got that, I think the best would be to already engage the consumers of this data upfront before even the study is done. And offer issues around collaboration in terms of having to work together and all that, because once the results comes through, then already there's ownership because you've taken the stakeholders along the journey as that work has been done. I think for me, that has been one kind of area that has worked quite well, because I mean, we're coming from confusion in South Africa, where each and every person will just do a study. whether they do it in country without us knowing or outside the country, but one way or the other, there'll be a result of some study that was done in some little corner in South Africa, and politicians will be bombarded with this information. And then it's got to come to us for program implementation. And we are confused because today we tell you this is the way to go, tomorrow is that the way to go. Then until such time that then there was a level of delegation of authority given to a management or a unit, like in this case was given to us to say, where I at some point, personally, I was labeled very arrogant, because then I would say you would not go and do any study in South Africa without us knowing. And then again, we've got to agree on the assumptions that goes into a study, because assumptions are very key as well, because the context under which you cost and it spews out the results, and the model that you're using as well spews out the results. Sometimes the results are not the same, even if you're costing the same thing. So the issue around then dissemination and ownership of that information comes as a result of having fostered, collaboration and consensus from the onset. Let me pack it there. Thanks.
Thank you. I think you couldn't have said it better. It's difficult for partners to do, but most times decision makers, if I was not aware you were going to do it, don't come to me with the result. I don't know what you've done. I don't know where you went. You could just be telling me stories, right? So that's just there by the side. So it's difficult, not impossible, but it's difficult. But I think one thing that really helps in terms of acceptability, it's a paradox, because it helps, but it should not be the case, is that of reputation. So if the costing is done by WHO, the kind of organizations that governments are most comfortable with, and say, we've done it, this is what we found, it's easier to accept, right? But that shouldn't be the case. What you really want is the costing to be done by people within the government establishment itself, and for people like WHO and partners and others to accept that, oh, these people know what they're doing and they've done this, and we accept it ourselves, not you always bringing it. That really helps. So they need to build capacity in-house first, within those that will accept the result and take the decisions, so that they understand when you speak to costing, you know what you're talking about. When you show your tables, they have an insight to what those tables mean. I think that's really critical and important. Then the culture of it that was mentioned in the presentation, it's a challenge, because it takes a long time. But what we could do and what we're advocating for is within the budgeting process and within the decision-making process to insert a step where we need to acknowledge or say that this costing has been done. We accept the costing, and the costing, these are the figures it shows, but we can't afford it anyway, so we're using 70% of it for now. So once that goes into it as practice, then over time it becomes a culture, and everybody wants to see what the costing has done and all of that. The last part I'll just mention in terms of acceptability is how the result is presented, back to the communication I was saying in the morning. And I think Genesis has some possible things to offer there. It's modeling. We are not able to tell politicians why we need money in the health sector. I don't know why. I don't have the answer, but we just don't do it right. Because once you finish, they've forgotten everything you said. So there needs to be a way to show that last year, this is what happened. Because you released only $1,000, 5 women died. Because when we costed, we required this to save every life. And because it wasn't enough. So we know that if you can release $2,000 this year, only 1 woman will die. And in a believable manner, in an animated manner that it sees it and is real, the numbers don't mean anything to them. At the end of the numbers only mean one thing. How much are they asking for? 10,000. We don't have it now. Talk to them. They need to come down. So, but when you be able to model it, and that too, there's a lot of capacity gap in that. So I think these are some of the real ways we build the capacity. We insert a step in the process over time, so we build a culture, and then we try to also create a reputation within the government institutions in terms of they know how to cost, and we accept it as practitioners and partners, and not just all the time partners coming up with the costing. Thank you.
Okay, I would take the question on independent bodies for costing data. It's quite it's quite difficult. On a personal basis, I think having a body that is yes, public body that is mandated to do perhaps both costing and HTA. I think that would be my preference, because of several issues. So first of all, at least then they'll have the mandate to produce the costing data. In the ministries of health or what we have a very huge mandate, and sometimes issues of to provide up-to-date costs may not be the priority. But if you want to have cost data that is regularly updated, and you also know where to get it, when you get it, I think that's then an independent public body would be the best. However, I would also like to emphasize what my colleagues have done here, that at least when you create such a body, the service delivery practitioners, and also perhaps not perhaps, but the Minister of Health, you should be able to know and perhaps co-create the process. You understand it before that this is the costing that we're going to do. These are the methods that we're going to use, and the policy questions that we want to answer are these, and it will help us in this and this and this. So in terms of having consistency in the production of costing data, yes, a public independent body is better in that way. But again, to emphasize, that process must be co-created between or amongst the major stakeholders. Thank you.
Thank you so much, Dr. Mandike. Please, let's appreciate this excellent panel. Yes, so for want of time, we'd like to stop here, but just know that you can come up to the panelists after now and even during lunch to get some of your remaining questions answered. So at this point, I would like to invite my colleague, Mike Acho, for want of time, to give a very quick summary across the 3 key sessions that we've had today. So Mark, over to you.
Yeah, thank you very much. It's hard to put all this quickly in a summary, but thank you very much for the presenters today. I think we've all learned a lot, getting to know, understand the challenges with costing and the data collection as well. But I think the emerging questions, or if you want, the emerging themes from this discussion, I've tried to summarize them into 9 main points. We all understood the challenges really with, the methodology of costing, and we're saying that if there's a better way to simplify these processes, then we can use that actually for our planning. So if it has to take 6 months to get this data or the process completed, and we have, usually the cycle of budgeting and planning is within a few months, then that is really not responding to the needs of the policymaker. So a very simplified way of collecting and analyzing the costing data would ensure that we're able to do this. Aligned to that is, how do we then embed the costing process in existing systems? Could be, the information systems like the IFME system, or even the public financial management system in its entirety. This, I think, would partly address some of these, lengthier processes, as well as, the inconsistencies in the process. Now, we also mentioned time and again that we need, some kind of capacity building, a deliberate one that is building the capacities at the partners level to ensure that they have the skill to use the process, the methodologies, and as well as use the results emerging from that. As a process, so institutionalizing the costing exercise within the policy makers level. Now, linked to that is the question of ownership, and I think just about a while ago we're discussing about how do we ensure that there is some consensus on the methodologies or the results that is eventually generated from the costing exercises? And so there's a need for co-creation, as we've mentioned it again, which would be co-creating with the development partners, academia, as well as, you know, the decision makers, to ensure that, you know, right from the design, we're getting the methodology right, and then the processes are, you know, jointly done together. So we cannot, at the end of the exercise, say, well, the results is not acceptable because, you know, there wasn't some kind of independence with that. Also, we said, you know, the costing eventually should lead to some efficiency, prioritization. So is it possible to already from the point of the process starting point, how do we integrate this in the budgeting and planning process as a routine way of planning at the health system level? The fifth point is, you know, costing results as to, I mean, I remember the panel before this, we're discussing, you know, often we are interested in knowing the cost, but we're not really also articulating who is paying for what. And so it will be important that our results are also reflecting who is paying what of the cost already within the system. And link to that would be, if there are efficiency gains, how do we also bring that into the results that we are presenting? Of course, if there are also inefficiencies, how do we accommodate for that? And then, you know, typically there's the assumptions around the utilization, as well as, you know, the coverage and its as a whole. So if we can build some kind of robust mechanism or system of really estimating the utilization, that would help us in our estimates as well. And then communication, I think I cannot overemphasize this. The communication is becoming more and more. Usually we tend to think of this as a soft part, but I think it's the most difficult part. Getting to clearly communicate the objectives of the costing study, and then making sure that we're communicating the results in a language that the partner understands, and make sure that, you know, we can use those results for the decision making and prioritization of the health system. And then finally, develop better methodologies for effective allocation of indirect cost. I think we all spoke about this, and I remember Carl had mentioned that we're getting better at allocating the direct cost, but there's still some gap when it comes to the indirect cost. I think we have to think through this and how to refine this, make sure that we're actually doing a proper costing in terms of the indirect cost. Thank you very much. I think if you have other high-level reflection, it would be nice to share, but thanks.
Okay, thank you so much. Just on behalf of Palladium and all of our sponsors, USAID and IHEA, we'd really like to offer our appreciation for all of the panelists and collaborators that made today possible, in particular Genesis, all of the representatives from ministries of health, social security departments, and all of you for taking your morning and spending it with us. We know there were a lot of other competing pre-Congress sessions, and we appreciate you choosing to be here with us. So with that, I wish you well. I think, though, as many people said, most of us are going to be here over the coming days, and we look forward to having more opportunity to talk with you and to network and find opportunities for collaboration to move forward. Thank you very much.